Thank you, Prof. Raja and Professor Kato, Professor Kodeswaran. Today is, I think, we have a first time dedicated ACNS neuroplastic surgery webinar, and main key person is Professor Kodeswaran to make this again reality. So without further ado, I would like to invite Professor Kodeswaran to be the first speaker, who will speak on an overview and introduction to neuroplastic surgery. Please, Professor.
Yes. Can you see my screen?
No, you have to share still. Did you click the green button, share?
Yeah.
Yeah, now it's coming.
Now it's visible?
Okay.
Yeah. First of all, I would like to thank Professor 𝒂𝒃𝒂𝒏 ma'am and her team for allowing this platform to us to start this new subspecialty in neurosurgery. Basically, it is a new super subspecialty of neuroplastic surgery, and also it is not picked up very well all over the world. So the main concept of this specialty is neurosurgeons doing cosmetic work with the collaboration of other subspecialties like oculoplasty, plastic surgery, and facial-maxillary surgery. So it has a huge demand in the world among neurosurgical patients. So what is the importance of neuroplastic surgery? Cosmetic neurosurgery in neurosurgical patients will reshape not only the physical appearance, and also it will improve self-confidence and emotional well-being of the patient. And also it will do some meaningful change in somebody's life. The demand in neuroplastic surgery in a lot of neurosurgical patients like complex head trauma, spinal dysraphism, developmental disorder like craniosynostosis, and skull and scalp tumor reconstruction, and also in bed sores. This is an example. It's a patient who has a complex head trauma, which involves head injury, orbital injury, facial injury, and also dental injuries. These kind of patients are transferred because of head injury to neurosurgical department, where the neurosurgical problems addressed properly, and the other parts was not addressed properly because lacking teamwork with other subspecialties. So this kind of patients, from admission itself, the other subspecialties also should be involved, and also the treatment should be done primarily. That is the concept of neuroplastic surgery. So the primary fronto-orbitofacial reconstruction is done in these kind of patients, will give very good cosmetic results. The another important area is spinal dysraphism, where the neonates and pediatric patients will have a bad cosmetic problem along with that spinal dysraphism. If it is not treated properly, they'll definitely develop a poor cosmetic outcome, and also CSF leak, and also will lead to meningitis. The another area where neuroplastic surgery comes in is craniosynostosis, where the patient require a cosmetic surgery for their brain growth and also for their development. There's another very complex area where fronto-orbital tumors. This is a patient who underwent surgery for a complex orbital tumor, which is extending to anterior cranial fossa and middle cranial fossa base, which is very complex to operate. So this patient underwent multiple surgeries, and also he was not cured properly because of the coordination of multiple subspecialties like oculoplasty and also plastic team. So this is one of the major area where neuroplastic surgery plays a big role. So I'm going to share a few of my experience in the past 2 decades. So patients with complex head injuries are given importance for life-saving procedures than cosmetic procedure. So the neuroplastic surgery emphasizes again and again, it needs the correction of cosmetic problem also along with primary head injury treatment. This is one of the example where the patient was having a complex fronto-orbitofacial problem. This patient was treated in 2010. This was one of the few cases we operated in 2010 when I was in my beginning of my career. He was one of my eye-opener for this neuroplastic surgery. So this patient had a complex frontal fracture, nasal fracture, skull base fracture, and also facial fracture. So initially I corrected with the primitive implants, which was available during that time, the frontal area, frontal elevation, and also frontal reconstruction. After that, the plastic team took over and they corrected the nasal part, and the oculoplasty team took over. So they corrected the orbital part. At the end, facial-maxillary team corrected the facial fractures. So this was the final result after the complete surgery. This is the patient immediate post-op. This is the patient after 3 months. So we have tried to give a cosmetic outcome for this patient with the complete complex fronto-orbitofacial trauma. In pediatric age group, spinal dystrophism with lipomyelomenincocele, it is very difficult to treat with the neurosurgical team alone. So it needs proper planning in the pre-surgical time itself. We have to plan properly for the flap cover. Once you remove the lipomyelomenincocele or myelocele or meningocele, it will be a great dead space. It will be very big dead space at this area of pathology, and it needs proper planning. This is one of our patient who had a myelocele at the back. This is the neon, actually very few days after birth. This child we planned along with our plastic surgery team. So we planned the flap properly, and the sac was excised, and proper correction and cosmetic results were given for this child. This is another area where craniosynostosis. So this patient had premature closure of sutures. So we did strip craniectomy of coronal suture and sagittal suture. This is after the strip craniectomy. This is a child after completion of the procedure. So, as I said already, the patients with complex head injuries are given importance to life-saving procedures than cosmetic procedure. So it lead to very big skull defects and deformities. So in our hospital, it's a government institution. We have started doing 3D printed implants for needy patients. And free of cost, we have a government scheme which gives the implant cost free. So we used to do a pre-op planning. Our radiology team will do a planning for us. Then we do custom-made patient-specific implant. This is a patient who had bilateral very bad skull defect. So we did the pre-op planning for this patient. This was the model which was used during planning. So 3D printing was done. He had a bilateral frontotemporoparietal defect with a very bad cosmetic appearance, and his patient-specific implant was printed. This is the patient after completion of the procedure, which has good. He had a very good cosmetic outcome. This is another patient, young boy. who is studying in college, who had a head injury, and he had a very bad cosmetic defect following his head trauma. The frontal bone was shattered and it was removed. This is the patient. So we had the same treatment option for him, patient-specific implant. This is the model which was used for designing and printing. So we used 3D mirroring method for this patient. This is the mesh which was designed for him preoperatively using 3D mirroring. This is the patient after completion of procedure. This is a young girl who had a very complex frontoorbital tumor. There's a neurofibroma which was operated multiple times, and the tumor was recurring again and again. So we, Dr. Preeti and me, operated this case. It was a very complex frontoorbital tumor. We operated for her before almost 4-5 years back. This is the mass which was protruding through the orbit, and also it is displacing the orbit, and almost it is coming out of the orbital cavity, and she was operated through frontozygomatic approach. The tumor was not removed properly and the recurrence was happening again. So this was a child. So these were multiple scars due to previous surgeries. This is the orbital exposure. This is the orbital exposure and also cranial exposure. Tumor was excised from the frontal area. Then our Dr. Preeti was exposing the orbit and she was removing the tumor from the down. This is a total tumor excision was done. Then we did cranioplasty from the top and also orbitozygomatic correction from the below. This is a child after the surgery. The tumor was totally removed. Now she is doing fine. There was no recurrence. This is a delayed fronto-orbitofacial correction. This was a boy who came from other country to us. This was done with our Dr. Anand facial maxillary team. He had a blowout fracture of the orbit, and this was operated in their country, and it was not fixed properly because the neurosurgeon alone was doing this procedure. The orbital component was not treated properly, and also facial component also not treated properly. So now this is the scan which he was having before the surgery. You can see the displacement of lateral orbital wall here. And also you can see the floor of orbit fracture. The orbital content was protruding through the maxillary sinus. This is the pre-op picture who had very bad cosmetic defect in the fronto-orbitofacial region. This is the after surgery. The frontal portion was corrected, medial orbital wall was corrected, and floor was corrected. Orbit was lifted from the maxillary sinus. Floor was corrected. This was the post-op CT scan. Now most of the problems are corrected. This was the post-op status of the patient. The another area which needs a complex surgical plan, and also we did along with my plastic team, Dr. Girish. So this is a patient who had a complex atypical meningioma, which was extending from the frontal region and extending through the skin, and also around 6 to 7 centimeter skin was involved. And it was almost the skin was not separable from the bone. This was the patient. So we rotated the flap. So we planned properly along with the vascularity of the flap. So we have to excise the area which was involved by the tumor. It's almost 6 to 7 centimeter. Either the two options, or either you have to put a pedicle flap or you have to rotate. So this patient underwent a rotational flap. The skin was excised along with the tumor. This was the tumor. So there was a huge defect in the frontal area along with the bone was removed. So this is the flap. scoring of flap was done. So this is the patient after the surgery. Because it was atypical meningioma, he underwent radiotherapy. Now cosmetic outcome was better because of pre-op planning with the plastic team. And also bed sores is another area where neuroplastic work is requires. So this is the multiple flap cover. Because the bed sores are not treated properly, it requires a lot of financial burden to the family, and it will lead to long-term stay in the hospital. So another interesting story, which was eye-opener for me to develop this field. This was a young boy whose marriage was fixed almost a month later. He met with an accident, and he had a very bad fronto-orbital trauma. And the girl which was fixed for him denied to marry him. Basically, they were from Orthodox Muslim family. So I counseled the girl and I asked her to wait for 6 months. If I make him all right, you marry him. Otherwise, you decide, I told her. So she agreed to wait for 6 months. So this was surgery which was done in my initial days, almost in 15 years back. So we did correction of the frontal part and also orbital part. So this is immediately after surgery. This is after 6 months. After 6 months, they got married. So it is one of the interesting story of neuroplastic surgery. So I presented a series of fronto-orbital injuries. I proposed that time it's a mainstay of treatment is primary fronto-orbitofacial correction, which was presented in 2013 Seoul World Congress of Neurological Surgeons. This is one of our publications, a call for neuroplastic surgery in Asian subcontinent, because it was started already in United States. This is a reply to our publication from Iran. Dr. Syed Ali Hamadi was responding that it needs a huge demand in Asian and European area. So this is our team: Dr. Preeti Uday, oculoplastic surgeon; Dr. Anand Narayanan, facial maxillary surgeon; Dr. Girish Ambat, plastic surgeon. So these kind of procedures should be started in neurosurgical department, and the ultimate benefit is cosmetic appearance of the patient. So everyone will have a happy feeling after undergoing these procedures. So we have started a WhatsApp group, World Neuroplastic Surgery, to establish this specialty under the blessing of Professor 𝒂𝒂𝒂𝒊 ma'am. So thank you all for your attention.
So I think it's a great talk. Thank you so much.
Thank you.
So I think, yes, so of course, as a neurosurgeon, we have so many encountered such cases. Recently, we had a very huge meningioma case, and excess skin after the growing the tumor up to the skin. So I think for all that such case, I think we need some help, the plastic surgeon, and sometimes we modify the skin. Sometimes the tumor invaded the skin, so maybe for that case is maybe such maybe big surgery will be needed, such rotated flap, something like that. So I think it's very important point you pointed out, I think.
Yes.
So yes, I want to ask. So your suggestion is to create such the group.
Yes, ma'am.
The new subspecialty.
Yes. So because people will know about this, no, the problem is, recently we were discussing with Dr. Preeti. So most of the neurosurgeons doesn't know about oculoplasty, because it was a very huge demand in neurosurgical patients. Orbital injuries were very common, because whenever the patient gets frontal injury, almost all the patients will have orbital injury. So when you coordinate with oculoplasty people, the outcome will be better. We can save the vision, and also we can give a very good cosmetic outcome. So this knowledge should be spread to the neurosurgical population first. Second, who are all interested in these kind of procedures, they'll get some training along with the other subspecialties like maxillofacial, oculoplasty, and also plastic team. So we should start organizing some teaching programs like this. So the trauma population is almost 1/3 of neurosurgical procedures in all parts of the world. So in US, they have started this fellowship program in uh, some areas. Only one program has neuroplastic fellowship. So we are trying to start this training program in India. So this should be started under the banner of ACNS, and also it should spread all over the world. That is my aim.
That's a great intention. I think it's very, very important. But I think as a neurosurgeon, we need to study such another field. Is that your point?
Yes, ma'am. We should know about that other area which is useful for our surgical treatments also.
Okay, so from the beginning, when we do the surgery as a neurosurgeon, maybe we can think about how we can incise the skin, something like that.
Yes, ma'am.
Okay, thanks so much. Okay, Dr. Lee?
Thanks, Professor. Thanks for a nice lecture. I have two basic questions, Professor. Regarding rear plastic surgery, as far as I know, they only deal with skin, soft tissue only. Most of the bony part, there are other specialty are dealing, and this is very special for neurosurgery because we deal with the bone, especially the skull bone. So, in your opinion, how far can we extend in terms of neuroplasticity? Because we tend to harvest tissue from other part like fascia lata. What else can we do? Especially in the cranioplasty, I find that at the moment, those who do not have own bone, I find the titanium mesh is still a problem. Sometimes it can cause thinning of the skin and erosion. And now we are moving towards the PEEK material. We do not know how much it helpful because we just started, because it used to be very expensive. Now it's slightly cheaper where we can do a 3D print of the PEEK material. So what's your opinion regarding this? Thank you, Professor.
As you said, it is a very good point because titanium is the commonest material what we are using in our hospital, because we are doing the implant in our hospital for less than 30,000 rupees, almost less than 350 USD. So equivalent to 350 USD. So that was also 3D printed patient specific implant. That is, the government is sponsoring the money through a special scheme called comprehensive insurance scheme for needy people. The next major issue is PEEK. The PEEK is very expensive because if you go for a PEEK implant in India, it costs around more than 1,000 to 1,500 US dollars. So it is equivalent to 1,500 US dollars. Now the costs are coming down. But what are all the implants we are using, that is not important. The vascularity is important. For example, if you have a very bad skin, you should have a cover with the pedicle flap. If you don't have a problem with vascularity, because the scalp is very highly vascular structure, which is having a very good chance of healing even if you have a very bad injury. Recently, we did one surgery because the patient underwent multiple surgeries. The skin was very thin. If you have a problem like that, you should plan in advance to cover that area which is going to lack of blood supply. So that area should be planned along with the plastic surgery team or who's the person who is doing pedicle flap. So you should always, the vascularity is the mainstay other than implants. Implant cost is a very big factor, but whenever you do a cranioplasty or a patient-specific implant procedure, you should think of vascularity. That is more important.
Thank you, Professor.
Okay. Maybe I think Dr. 𝒂𝒂𝒂𝒂𝒂, are you with us now? Dr. 𝒂𝒂𝒂𝒂𝒂? Or maybe Dr. Jeremy? Dr. Jeremy?
Hello, Professor.
Hi, how are you? So
Fine.
he's from Kenya,
Yes.
Kodiswaran. So maybe can you make some comment, please? You may have lots of trauma case, I think.
Thank you for this opportunity, Professor. And thank you, Professor Hodgson, for the wonderful lecture.
Yes,
One
Nirjan.
of the challenges we have in our country sometimes is the coordination between the different departments, especially the plastic surgeons or the oculoplastic surgeons, just to bring them into the team to coordinate such major surgeries. I don't know, maybe from your center, how are you able to coordinate these two teams to be able to combine your efforts together so that you made this you made this neuroplastic department a workable department? Maybe probably you can tell us what you're able to do with the two departments. Thank you.
Yes, actually, the collaboration is very important because we are all almost like friends for a long time. Almost we are doing these procedures for more than 2 decades. So initially, accidentally, we started doing a case which has a very big foreign body which is started entering through the eye and it is gone through the skull base. So I don't know how to operate. The ophthalmic surgeon, Dr. Preeti, she was also worried whether while she operating, the chances of brain injury was very high. So that is the time we started in 2008 or 2009. So from then I'm learning good things from her. She's learning good things from me. Similarly, the plastic team, we have very good, the main idea behind this, you should have very good relationship with your colleagues. So learning from them and teaching them is not a problem for us. So we learn every day. Each and every case is a lesson for us. So whenever we get a patient, we used to plan properly. We take time. At least we take a week or two to plan the patient properly. And also, based upon the patient situation, we will discuss together. We'll have a meeting and also we'll have multiple discussion to sort out. We also analyze what are the complications we are going to get. So we try to avoid all those complications. Even we get a lot of complications. Because the patients we are handling all are complex. So already most of the patients were treated multiple times, operated multiple times. They're coming here. So without no other option. So we used to get complications also. The thing is, if you have very good coordination with your colleagues, you will give fantastic results. Dr. Preeti also will have some good experience on that. She can also share her experience. Dr. Preeti?
Yeah. I think I'm going to show those cases in my talk. The foreign body case I have already in my talk. And yes, we have been collaborating for the last 15 to 18 years. And we've had tremendous learning experience with my other colleague, also Dr. Anand, facial max surgeon. I know him for 18 years from the time I was doing my fellowship. Dr. Kodishwaran, I'll show you cases which we have done 15 to 17 years back. And we have ourselves improvised on our techniques, and I will show you some of the recent ones where we have used advanced technique to reconstruct. It's amazing. It's an amazing platform, and I'm glad I'm here today and connecting with you all.
Maybe one more guest, Dr. 𝒓𝒂𝒂𝒓. Dr. 𝒓𝒂𝒂𝒓.
Good evening, everyone.
Hi, good evening. How are you? She's from Sudan. Please.
I have one comment. In Sudan, we have this the similar team to work on complex retroorbital tumors, but it was in only one center, the police center, hospital center mainly. It's composed of the same team, maxillofacial team, ophthalmologist, and our team, neurosurgical team. But we didn't involve the plastic surgeon in most of the cases. But I think this is a good idea because me myself, I face a lot of cases which I need the help of plastic surgeon, mainly while I'm treating meningocele patients. You have a wide defect and you need to do a rotation flap. Sometimes because I don't exposed to this part of training, the wound usually dehiscent, and I get so many infections and some because I don't know the how to do a rotational flap or to do it or close it in a proper way. So I think that the collaboration with the plastic surgeon or the generation of or establishment of this neuroplastics subspecialty will be a good for us and for our patients. Thank you.
Thank you very much. Dr. Lee?
In this seat, thank you. Since there are no further question, give me a great honor to call upon Dr. 𝒂𝒂𝒂𝒓, who is an oculoplasty surgeon. Actually, I think many surgeons have worked with oculoplasty surgeon in many occasions, and she'll be talk on post-traumatic frontal orbital reconstruction and the soft tissue sequelae. Let's welcome Dr. 𝒂𝒂𝒂𝒓.
Thank you very much for this great honor, and it's a privilege to be here today. Unfortunately, few of the cases might overlap here, but I will be discussing it from the oculoplasty point of view. I'll discuss some of the post-traumatic frontal-orbital reconstruction that we have done together, Dr. Kodishwaran, Dr. Anant, and myself. So this is the same patient that Dr. Kodishwaran has shown us, but from the oculoplasty point of view, I will show you actually the surgery. Here you see our team. Dr. Kodishwaran is here. Now, since this was a secondary reconstruction, we are osteotomizing the fused bones by using high-speed cutting saw with a guard. Here, this is Dr. Kodishwaran, who is now mobilizing the fractured fragments. And that's the roof in my hand, a part of the orbital roof with the rim. I'm trimming the edge a little bit so that it fits a little better. And once these fragments are in position, then we keep them together with a titanium mesh. Now, this mesh was manually contoured because the defect was not all that large. But if we have a large defect, we get a patient-specific implant. Now, these implants are manufactured in India, so we get them at a lower price compared to previously. Now, this was the mesh which was used to reconstruct the superior orbital rim also in this case, along with the frontal bone. And once the roof was set in place, we then went to the floor. We reconstructed the floor with a pre-contoured 3D titanium implant. And some bone piece which was left from this reconstruction, I have used to augment the lateral orbital volume. I will show you that in a minute. So this is how the patient looked intraoperatively. This is the floor mesh that I have used. We have used a conjunctival approach to do this reconstruction. And now, post-operatively, you can see that the implants are in place, but the patient has a total ptosis. Because this is explained to the patient previously, because once you dissect the superior orbital rim, the Whitnell's ligament and the pulley system gets disturbed, and that affects the lower eyelid position, and the patient develops a total ptosis. So this is the Whitnell's ligament. It is a condensation of the fascia, which is surrounding the levator aponeurosis. It runs transversely about 4 millimeter posterior to the rim. So you can see the rim here, and this is the Whitnell's ligament. So when you recreate the rim with a titanium mesh, you tend to damage this system, and that causes a total ptosis. This pulley is required because it acts also as a fulcrum wherein the horizontal fibers of the levator turn into the vertical aponeurosis. Now, reconstructing this eyelid or correcting the ptosis in these patients is quite difficult because even when we advance the levator and reattach it to the tarsus, there is a very thick cicatrix along the superior orbital rim, and the patient tends to have very severe lagophthalmos in the postoperative period, which is difficult to treat. So this is the surgery that I did subsequently for the levator muscles. So when he developed a total ptosis, I'm first dissecting the levator muscle. So this is the tarsus. I'm dissecting the levator from the conjunctival side first, which is the least scarred surface. And then I'm holding the levator with the forceps and separating the septum from the anterior surface of the levator. So you can see the amount of scar tissue that is there. As I go further higher, I will show you the Whitnell's ligament, how it looks like. Now, this is the separation of fibrous tissue around the levator muscle superiorly, and the conjunctiva, you can see the cornea through that thin conjunctiva. Now, this is the septum being opened, and you can see preoperative fat here. This is the fat. Some more septum opening and the fat. And that is the Whitnell's ligament, the horizontal condensation here. And then I'm advancing the levator and reattaching it to the tarsus, and once I'm satisfied with the lid height, I am excising the scarred levator. Some amount of scarred orbicularis is also excised, and then the skin is closed. So that is, and then the patient looked like this at the end of the procedure. So now these patients in the post-op period also, we use antimetabolites like 5-fluorouracil injections to prevent that cicatrix from forming in the superior orbital rim. However, what I have seen in my patients is that if the superior orbital rim is not dissected too much, you just fall short of the superior orbital rim, this kind of ptosis does not happen. Like in this patient who has a hypotropia, you can see that there has been some amount of suturing done elsewhere. This was the fracture that was seen. The fractured fragment was abutting against the superior rectus muscle. He also has an extradural hemorrhage. And this patient the fracture was exposed by a coronal approach. We made a burr hole near the fractured fragment so that we can slip in our elevating instruments through that, elevate the fractured fragment, and then reconstruct it with a titanium mesh. Now here, the bony fragment along the superior orbital roof was large. And when we removed that fragment, we had to reconstruct with a porous polyethylene implant, which we placed between the frontal lobe as well as the orbital roof. And here I have also used a superior lid crease approach to enter into the orbit so that you don't have to dissect up to the mid-orbit from the neurosurgery side. This was a very nice advancement that we did. We do both the approaches, trans bicoronal as well as a superior lid crease approach, so that the tissue in between is untouched. And the patient did very well post-operatively. You can see he has no ptosis and his eyeball position is also corrected and there was no diplopia. This was another patient who came to me for ptosis correction, but this was a pseudotosis because of a hypotropia. And he had a similar fracture like this, but the bone fragment which was within the orbit was very small. So here we did not reconstruct the roof, but we reconstructed the frontal bone. And this was the titanium mesh that was used. Again, we have used two approaches here so that you can also monitor the pupil when you're inside the orbit, and you can elevate the depressed fragment from the orbital side very comfortably. And this was the post-op result without a ptosis correction. Now, another similar patient, the eyeball is displaced outwards and downwards. There is a similar fracture here. The fragment is abutting on the superior rectus LPS complex, and this was after the surgery. Now, this was another patient who had a bullhorn injury. Here in Tamil Nadu, there is a bullfighting sport which is very popular called Jallikat, and this child was injured in that sport. And here what I wanted to show is that the reconstruction of the roof, if we are not able to do from the neurosurgery side, we can also place in a titanium mesh from the orbital side, and you can see that in the coronal images. Now, these are transgressing from my topic, but what I want to reiterate here is that we are able to separate the levator muscle in these complex cases also now under the microscope, and we can give these patients functional eyelids, like in these cases of AV malformations as well as in neurofibromas. We are able to separate the levator muscle, reattach the levator, and give them good functional eyelids. Like these cases are very complex. Earlier, we used to do only frontalis sling, but now we are able to resect the levator and give them functional eyelids. Now, this was another trauma patient who had a raccoon eye and this kind of a fracture. She had CSF rhinorrhea, and the entire fractured fragment was actually touching the eyeball. This was the intraoperative picture, and again, we have corrected her CSF leak as well as repaired the frontal bone with a titanium mesh. And post-operatively, the small fragment which was abutting on the eyeball we have removed, but since the fragment was small, we have not reconstructed that area, and she looked well in the post-op period. Now, this was the foreign body case that Dr. Kodishwaran was talking about. It was a large wooden foreign body. It came to us after a week of injury. So he already had lost his vision and there was scleral necrosis. This was the foreign body, which was almost 8 centimeters long, extending from the orbit to the intracranial structure. Luckily, it was from the medial side to the lateral side, so it spared the carotid artery and the midline vital structures. Now, here is a video which shows the entire surgery. I have done an evisceration for this patient because there was already scleral necrosis and there was no visual prognosis. Once the eyeball was removed, we dissected the foreign body carefully. Now, since this wood was inside for 1 week, it tends to soak in the body fluids and it gets very, very fragile. It tends to fragment when you remove it. And we must remove these foreign bodies in the same trajectory as it enters so that we do not extend the fracture to the surrounding areas. I have retained the scleral shell here to give some kind of volume to the remaining socket. So this is the foreign body, and we are gently trying to remove. This was a small fragment that came off first. And there was another large piece inside. which was separated carefully. These tend to be impacted quite often because they create a fracture which tends to impact this foreign body. He had a large zygoma fracture and the greater wing of sphenoid fracture. I don't know. So this was the foreign body and there was a lot of purulent material which came out. I reconstructed the socket with a dermis fat graft postoperatively because the socket had contracted because of prolonged infection. And also the eyelid needed reconstruction because of eyelid necrosis. That is the purulent material which we are sending for microbiology. So a reconstruction after this kind of surgery is more difficult because of the severe injury and the necrosis that happens because of delay in the treatment. And this patient had a prosthetic eye. He is still on follow-up with us after 15 years. He's doing pretty well. We recently saw him. So this was the post-op picture of this patient. So this is the kind of dermis fat graft that we use to augment the lining as well as the volume in the socket. We remove the epidermis and use the dermis and the fat to augment the volume. Now we had another patient who had a laceration running through the upper eyelid. He had a roof, medial wall and floor fracture. And he also had a telecanthus. So here we have done a 3D printed skull model to plan the surgery. We have removed this bony callus and pre-contoured a titanium mesh. And since he didn't have a seeing eye because his eyeball was also injured, it was a icicle eye, we have removed the lacrimal drainage system and used this mesh to correct the telecanthus. We have used navigation guided surgery in this. Anant is here with me. And navigation is useful in this case so that the two sides of the orbit are symmetrized. So the pink here is the mirror image of the normal orbit. And we use this image as a template for reconstruction when we reconstruct this kind of a severe trauma. So here the titanium mesh is in place. And once the mesh is in place, we check the position by using the navigation probe. So that we know that the junction between the floor and the medial wall is correct. So this is the navigation probe that we are using. And that on the screen, we can know whether our implant is in position or not. And once we are satisfied with the implant position, I am doing the telecanthus repair. That is, I'm anchoring the medial canthal tendon to the posterior lacrimal crest. Now, since the posterior lacrimal crest is difficult to reach, this kind of a mesh is very useful for reconstruction of these cases. You can see the eye tracker here of the navigation. So post-operatively, you can see both the orbits are symmetrized very well. I also did a levator resection for this patient for the ptosis correction and gave him a prosthetic eye, and you can see the symmetry is quite good. So this reiterates the importance of doing a bony as well as soft tissue reconstruction together in the same sitting. Now, another patient here who had a trauma at 6 years of age. So it is a childhood trauma and some amount of bony hypoplasia was also added. And she has had some 4 or 5 surgeries in the past. There was an attempt to do a telecanthus repair. Also, you can see the wire here. But she has this kind of a bony callus similar to the previous patient, which we have removed. And we have used a floor and medial wall implant for reconstructing the floor and medial wall and also done a telecanthus repair. Now, in this case, the patient did not want any interference with the other side, so we cannot do a transnasal wiring for her. So we have used a Y plate here for reconstructing the telecanthus. So in these cases, the Y plate, we use a Y plate so that we can reach the posterior lacrimal crest comfortably. I'm passing a 2-0 proline suture through the medial canthal tendon, and then this suture is passed through a 26 gauge wire. And this wire is then passed through the lowest hole of the Y plate. Here, this is the Y plate, and now the medial canthal tendon is attached to the lowest hole of the Y plate, which will be placed and positioned at the level of the posterior lacrimal crest. And the 2 arms of the Y will be then fixed anteriorly to the stable bone, which is available in these kind of cases. So this is a good option for telecanthus repair in these patients where we cannot do a transnasal wiring as the patient is apprehensive about interference with the other side. And it is much simpler and faster procedure. So this is how the patient looked on table. The telecanthus was repaired very nicely. And post-operatively, I have a 3-week picture wherein the enophthalmos is corrected well, the telecanthus is corrected well, but she has exotropia and she needs a squint correction. Now, this was a very interesting case. He was a cyclist and he fell and he had injury, and the small fragment was abutting on the superior rectus muscle. The difficulty was that the fragment was very small and it was at the apex, very, very close to the optic nerve. And therefore, we used a navigation probe which has a look-ahead protocol. So we know from the trajectory where this foreign body lies, where this fragment lies. And through a small 8 millimeter incision at the superior lid crease, I could remove this bony fragment and correct his diplopia. So that is the beauty of navigation in these kind of cases. Now, when you have a very large defect like this, a manual contouring will not give you correct symmetry. So this patient had a tumor excision several times and he had this large cranial defect. In these cases, we need to design a PSI. So we mirror the normal side onto the abnormal side. So yellow is the mirrored image. And we design a PSI to match this yellow template. So we have designed a titanium implant for the skull and also a PEEK implant for the lateral orbital rim. This was the recent case that Dr. Kodishwaran has shown you. And this was the planning and this was the intraoperative implant. So a lot can be achieved with a team approach, and I'm really grateful and thankful for this wonderful opportunity. I think neuroplastic surgery is the need of the hour. Thank you very much for this wonderful meeting.
So thank you very much, Preeti. It was an excellent talk. Congratulations.
Thank
So just I want to ask, how soon such as related with the trauma of the eyeball, something like that. So what is your decision? Is that same time of the cranial surgery?
So normally we don't do an enucleation in patients because the patients also find it very difficult to accept. The primary enucleations are very, very rare. In my 15, 16 years, I would have done 1 or 2. And one of the cases is what I showed because it was a severe infection and the sclera was necrosed, and therefore we decided to remove the eye. But in most of the cases, even if it's a severe injury to the eyeball, we try to repair the eyeball primarily. We are not bothered much about sympathetic ophthalmia now because I am yet to see a single case of sympathetic ophthalmia, and these patients usually present to us quite late. And sympathetic ophthalmia can be prevented only if we remove the eyeball within 1 week or 10 days of the injury, which does not happen usually. And we have good treatment available in case sympathetic ophthalmia does occur in the other eye. So we do not do enucleations to prevent sympathetic ophthalmia any longer. And primary enucleations are just not acceptable. We usually try to close it as much as possible, allow the eye to go for phthisis. And that also gives us some amount of volume in the socket. And sometimes we don't need to remove the eyeball in future, and we can just use the prosthesis over that shrunken eyeball.
Okay, thanks a lot. So maybe little shot from Uzbekistan.
Yes.
Hi.
Thank you so much. Hello, everybody. Dr. Preeti, that was very interesting presentation. Very beautiful cases. My question is, in some surgeries, like after, it's not related to the neurotrauma actually. After skull-based surgeries, like resection of vestibular schwannoma, we have some complications related to ocular motility, like strabismus, postoperative strabismus, abducent nerve palsy. In that cases, is it possible to correct the eyeball mobility, at least for the cosmetic purposes?
Oh, yes. So there are now, even strabismus surgery has undergone a tremendous advancement. Even if you lose one muscle completely, we can use the surrounding muscle. We split the muscle into half and use half of medial rectus and half of the lateral rectus, and we can still reconstruct and give the patient a little bit of elevation. Our aim usually is to give them diplopia-free functional gaze, which is usually primary gaze and the reading gazes. But if the patient for his profession needs a superior gaze, then we need to correct that too. So that is possible. But if I have 1 more minute, I can show you even a 40 millimeter tumor can be easily removed from the conjunctival approach without even damaging any of the muscles, and the patient recovers all the motility within 2 days, I would say. So I'll just take one more minute, and if there is time, I can share that small video. Do I have time?
Yes, please.
So this was a patient like that. He has a proptosis right eye, and you can see the size of this schwannoma. Okay, and this is removed from the superior lid crease approach, and it was almost 45 millimeter. You can see the size here.
Yeah.
And it is completely removed, and you see the patient's elevation, and this was the post-op. This is the pre and the post. So orbital tumors, virtually we do not have any post-op scars, any size we are able to remove from the orbital approach very comfortably. And in case we have damage to the muscles, we use microscope, we use cryopobes. So generally muscle trauma is rare, but if we do have that trauma, we will be able to correct it through strabismus surgery.
Very nice. Thank you.
Thank you.
Dr. Lim?
Yeah, thank you. Thank you, Professor Priti. I have one question, especially regarding cases that required exam direction. We have a case of CSF leakage. So how do you deal with it? Will you still go in through the eye, or do you think that we need some form of open cranial surgery for the dura repair? I just need to get some tips from you. Thank you.
I think Dr. Suresh Babu is here. We had some case like that, and he had done from the orbital approach. I don't treat CSF leak myself, but my colleagues are able to do it from the orbit. I'm sure Dr. Kodeshwaran must have done a few cases like that. I had one case which was an orbital varices, and because the varices had eroded the roof, when I was trying to remove the varices, I had a CSF leak which was repaired from the orbital approach by the neurosurgeon.
Yeah, Dr. Liu, actually recently we had a very complex case. The anterior skull base floor was totally shattered. So what we did, we opened from down and also opened from the top. So my ENT colleague opened from the down. He exposed where all the defects we have. The correctable defects from the down, he corrected through nose. The defects which are very anterior most, we have propose few approaches now. One is through transfrontal approach, that is I'm proposing a SIFA. So superior endoscopic transfrontal approach. The second approach, we routinely do a bifrontal craniotomy. So what we do, the defect is very big. We used to take the skull bone and we'll split into two, the skull bone graft. So you will lift the brain up along with the brain retractor. If the defect is too high, too large, we used to place the skull bone grafts in the defect area. Then we'll have a layer of fasciolata, and also we'll give the dural repair. So most of the leaks will settle down, even if it is a very bad leak. At the same time, simultaneously we used to examine through the endoscope through the nose. If there is a defect through the nose which was not arrested from the top, it will be sealed from the down. That is the technique we are using for very bad skull-based defects for CSF leak.
Thank you, Professor.
If I may ask a question, yes.
Jeremy?
Yes. I don't know if you have experience with the congenital pediatric deformities, like the patients with huge frontoethmoidal encephalocele that probably have facial deformities and orbital dystopias. I don't know if you have experience with that and what you've been able to do.
No, I don't treat those primarily. Usually it's a neurosurgeon who does those cases.
Okay.
Dr. Lee?
Since there's no further question, we thanks Dr. Priti, and we move on to the next speaker. Next speaker is Professor Anantana Rayanan. Paresmaran, who is a professor in oral and maxillofacial surgery. And he'll be talking on computer-assisted surgery in orbital facial and cranial reconstruction. Please welcome, Professor. Thank you.
Thank you, Professor Liu. Let me just get my presentation shared. Okay. So thanks a lot for this wonderful invite, and I'm extremely honored and privileged to be part of this particular program. My thanks go to the organizing committee of ACNS Neuroplastic Surgical webinar. And I should congratulate and thank Professor Koteshwaran actually. In fact, only after this invite did I actually manage to read his article, which was recently published, The Call for a New Subspecialty. I think it makes a lot of sense because over a period of time, we've been actually a group of good friends who've been working together. And I think this has to be floated into a better concept so that many people benefit out of this. There was a lot of interest from the earlier talks amongst the neurosurgeons who are attending this webinar, and I was able to appreciate that there is a very strong need for multi-specialty collaboration. And I think the reason for which Dr. Koteshwaran has given me this particular talk is to elaborate on the role of maybe primary or early secondary management of facial trauma along with head injuries. We all know that facial trauma and head injury go hand in hand. In fact, the incidence is anywhere between 20% and 85% when you're looking at involvement of the cranial bones or the brain in any form of facial trauma. So my primary focus is to elaborate on the role for collaborative efforts in primary or early secondary reconstruction with the aid of computer-assisted surgery. And I've taken the liberty of making this very simple into a semi-theoretical lecture with practical examples so that we are able to get the concept clear. And I wish the other specialties are also able to imbibe this and take adequate help or be of help to us when we need services from the neurosurgical side. So basically, the scope of this lecture would help us understand the elements of computer-assisted surgery. We'll look into the process of virtual surgical planning. We will have a little insight into developing patient-specific implants. We'll have an insight into guided surgery for orbitofacial injuries and how we have evolved as a team. Now, like Professor Koteshwaran as well as Dr. Preeti said, we've been working together for quite a number of years now, and we have developed our own workflow, and we've evolved over a period of time into achieving better outcomes for our patients. Now, to begin with, let's understand what exactly computer-assisted surgery is, because there are a lot of jargon associated with this. There is technology-assisted surgery, there's computer-assisted surgery. There is virtual planning and computer-assisted surgery. So a lot of things are there. In essence, all of them are quite similar. Basically, it is the use of digital data or what we call as DICOM data to plan, perform surgeries as well as assess post-surgical outcomes. So you are looking at a virtual image of the patient's CT data being created, which is going to help us in the preoperative diagnosis, intraoperative planning, as well as execution, as well as post-operative outcome evaluations. Now, let's have this the scheme which shows us how the CT data can be manipulated into different forms. So you have the CT data, you have a virtual image being created, you have the analysis and processing of the data, which can be used for diagnosis, where we can use multiplanar CT scans, volume rendering, as well as artificial intelligence and machine learning, which have come into vogue, which have become very, very popular in diagnostic processes these days. Then you have preoperative planning, where you can have virtual or physical models which help us or aid us in understanding the surgical process and help us plan and tailor make the surgical treatment for particular patients. Next comes surgical simulation. We will see the advantages of simulations when it comes to handling different treatment plans for the same patient, as well as determining which would work the best or finding out the best fit for that particular patient. Then you have intraoperative guidance, which is a range of devices or processes that can be used. For example, it can vary between stents and guides to intraoperative navigation, intraoperative imaging in the form of CTs and MRIs, as well as robotics. And then finally, not only do we get a lot of help in performing the procedures, but also we need computer-assisted surgical processes in establishing outcomes of what we have actually achieved. So which can essentially be performed by image fusion analysis. So when you look at computer-assisted surgery for diagnosis, basically it helps us to get a more accurate representation of the clinical problem, as well as enhancement of available information, which otherwise is in a very basic format. Now, when you look at presentation, what happens is when you look at a basic CT scan, you're looking at different images in different sections, the coronal, the axial, as well as the sagittal planes. But when you look at the simplest form is getting the reformatted three-dimensional volume models, which give us much more value-added data in terms of planning for the defect as well as accessing the defects. Now, this can not only be for the skeletal workflow, but also for soft tissue and access workflow. I have taken more onus on the skeletal workflow because Dr. Preeti has already covered soft tissue management. So I'll be focusing more on the hard tissue management. Now, when it comes for preoperative planning, it helps in better optimization of our workflow process so that we are able to understand whether we will face potential problems. That's a very, very important facet of computer-assisted surgery. There is a lot of areas where we can have markers which will help us troubleshoot potential problems during our surgical workflow. Simulation, the biggest advantage is to try out multiple options, as well as you can have feedbacks. Now, an important example for feedbacks is the use of haptics. You have virtual surgical planning systems which incorporate haptic feedbacks, wherein, for example, there was somebody who was interested in knowing about management of orbital dystopias secondary to pediatric problems, congenital problems or developmental problems. And in these cases, for you to understand how to design your osteotomies or the density of bone when you're going to cut, and whether you're in weak bone or dense bone, to plan your osteotomies, to plan your fixations, haptics plays a very important role, where you can understand the density of the tissue that you're cutting, as well as your fixation processes that go into the reconstruction formats. So this is how surgical simulation would be of tremendous help. The last and the most important thing before outcome analysis is intraoperative guidance. And basically, the role of intraoperative guidance is to do a predictable transfer from the planning platform into the surgical site, wherein we can perform the surgery with predictability and expect good outcomes. Now, this would range, like I said, between positioning guides, intraoperative navigation, or intraoperative imaging. Now, let's spend more time on understanding how positioning guides work. I've taken the example of facial fractures, so that's easy for us to understand. The concept of virtual surgical planning is much more simpler when it comes to cranial defects per se. I'm not saying craniofacial surgery, but cranial defects, because the cranium or the calvarium, in fact, is a very simple anatomical structure where the contours are less complex, while the facial contours are much more complex. So I've taken the example of facial contours to make this concept easily understandable. Now, when you have positioning devices, how does it actually work or play a role in the management of secondary trauma, where your trauma has already happened and the bones have already fused? In most cases, this is how we see the patients, because for the lack of a neuroplastic team at the current point of time, in most centers, there is less of primary facial trauma management during head injury management. So it's generally staged. There are a lot of cases where primary management may be possible, but it is not done because of lack of awareness and the lack of coherent teamwork being happening. So what happens when we deal with secondary trauma is you have united bones, and you have loss of facial contours, which are essentially very, very difficult to re-establish because of the hibernation process that happens. So basically, you have a fracture, we design positioning stents based on virtual surgical planning platforms, and these stents can be either used only for positioning or even for fixation of the facial bones after the virtual surgical planning. Now, how did these evolve? To walk you through this process in a very simple form, this was what we were doing about 10 to 15 years back. Now you can see that the earliest kind of planning systems that we had involved the use of CT scans, developing an STL model. And once you see the STL model, you can see that there are a lot of deformities that are there that need correction. So what we used to do is, we used to manually fracture or do a surgery on these STL models, reset them in a position that was comfortable for us manually, and then we used to again physically bend plates and then try to contour them in the best form fit. So this was what we were doing when about 15 years back. So it involved manual work more than a digital workflow. The only available digital workflow was in generating the stereolithographic model. Now, a good example of this would be something like this. This is a complex cranioorbital secondary deformity, which required correction, where there was a frontal bone defect, and then you had the zygomatic zygomatic complex, which was which had demonstrated significant dystropia, as well as the orbit was totally malaligned. Now, this was the earliest form how we used to do it. So an STL model was generated, a mock surgery was performed on the STL model, and we used to manually realign the bones, hold it with wax, and then we used to bend plates on them and then use them. And that was the outcome that we used to achieve. When you look at the skeletal form, you can see that there is the malunited zygoma, and how we have pre-bent plates, so that acts as an intraoperative guide for us to reposition the zygoma into the right place. So this was the earliest form of computer-assisted surgery that we were practicing. From there, we moved a little bit forward, where you had the CT scan and then you had a virtual surgery. So there was no necessity for an STL model on which a manual model surgery was performed. Now, instead of the manual model surgery, what we did was, we mirrored the normal side and took it to the abnormal side. For example, here, the left side is the normal side and the right side is the affected side. So what happens is, the mirroring of the left side was done and then taken to the right side. And on this particular model, we manually bend the plates. So this was the second generation of computer-assisted surgery, which we were practicing. A good example would be this, where you have a complex orbitozygomatic fracture with a lot of displacement, a large orbital blowout fracture, which was managed with the same workflow. So you had the affected side model, and then you had the mirrored model, and then all the implants were pre-bent on the mirrored model, so that we could recreate the anatomy on the opposite side. And that would be your final outcome. Now you can see that the symmetry of the zygomatic bone is reasonably in place, and the reconstruction of the internal orbit also is almost perfect. So this was the second generation of CAS that we were planning. Now that is again another CT scan which shows the symmetry that was able to be achieved because of this particular workflow. Now the next step, or what we follow currently, is completely virtual assisted with the digital workflow, as well as a patient-specific implant which is printed. So you have the CT scan again, you have the virtual surgery being performed. There is no scope of a model surgery. There is no manual plate bending. Instead, we design implants on the virtual model, which could be printed. Now, how does this work? So you have again an orbitofacial fracture, orbitozygomatic injury. You can see the gross displacement here, but you have multiple pieces of bones. For example, the zygomatic complex is broken into 1, 2, 3, 4, around 4 or 5 pieces. So what happens is, we segment the bones digitally, and then we align it to the mirroring from the opposite side. So the opposite side is mirrored and then superimposed on this side, and the individual bone segments are broken and aligned digitally with a workflow. Now, to recreate this on the patient, what happens is, we have something called as cutting guides. So when we osteotomize the patient, we use these cutting guides and then segment the bones in a particular fashion. And these holes which are there on the cutting guides will match to the fixation implants, which are like here. So automatically, when you cut the bones in this form, using the cutting guides, the fixation holes automatically correspond and get the bones in alignment. So this is how the final outcome falls in place. Now, this is a good example of how a digital workflow with PSI implants helps us in surgical work. So you can see a grossly displaced, the same case, it's this particular patient. So the grossly displaced zygoma with multiple pieces has been segmented using cutting guides and then fixed with patient-specific implants into the desired form and fit. Now, the next thing, once you start coming into this, you need to understand a little bit of detailing on patient-specific implants. Now, basically, patient-specific implants are personalized medical implants tailored to fit individuals, offering precision and improved outcomes in surgery. Now, this is the definition for patient-specific implants. So, where all can these implants be used? When you discuss the use of patient-specific implants, you can use it for performing an osteotomy, performing a resection. You can use it as a trimming and contouring guide. That is one important use where a patient-specific implant or a stent can be used. The second one is you can use it as an intraoperative guide for positioning fragments of bone and using it as fixation implants also. So it is used for not only repositioning bones, but also for fixing of different bony fragments after an osteotomy. And then the last use is as reconstruction for large defects. Now, when you see this, there are different forms of patient-specific implants, and they can be grouped as cutting guides, positioning guides, and implants for fixation or reconstruction. Now, let's have a look at individual components. So what exactly is a cutting guide? We already saw this. So a cutting guide is a guide which is manufactured in such a way that different bone fragments can be fractured in an intentional form to establish the final anatomy. So what you see is the workflow being followed for that particular patient. You have a displaced or a malunited zygoma. You have different cutting guides placed here, and you have grooves in this where the particular osteotomies can be made. So these osteotomies facilitate the bones to be moved in a particular fashion, as well as the holes, the screw holes on the cutting guides will match to the implants which are required for fixation. So these are the cutting guides which are in place when you perform the osteotomy, and the osteotomy is performed, the bones are mobilized, and then you can fix them. Now, what are positioning guides? Positioning guides are guides which are used for positioning different kinds of implants. For example, this is an intraorbital patient-specific implant, and to fix it in the right place, it looks as if it's easy to fix this, but remember that this can slide anywhere along the infraorbital rim. So what we generally design is, not only do we design the implant, but also we design a positioning guide which will synchronize with the holes on the implant. So this is the positioning guide. You can see the screen on the left side. So this is an acrylic or a polymeric positioning guide, and we place the holes first, and then automatically the titanium implant aligns with these holes and gives the best fit inside the orbit. So this is how you can use patient-specific implants as positioning guides for any implants that can be placed in the body. Now, sometimes what happens is the positioning guides themselves act as fixation implants, as in this case, where we use the cutting guide, we split the bone into multiple pieces, and then we've used the positioning guide itself as a fixation implant. So this whole implant has been printed in such a form that it not only repositions the bone, but also establishes fixation and can be left in situ. So this is the fixation for the frontozygomatic region, and that's the fixation for the infraorbital and zygomatic region. The last one is you have implants for defect bridging, or you have onlay implants. So when you have a defect that needs to be reconstructed or needs to be augmented, then you can use implants which can be designed as onlay implants. Now, for example, this particular patient underwent a series of 4 onlay implants. You can see 1, 2, 3, and 4, out of which we've used 2 different materials for reduction of weight for that particular patient, because titanium implants are slightly heavy. So the intraorbital implant alone was processed with titanium, which can be seen in this image, while all the other implants are made of PEEK. So that makes the implants lighter And the reason why we've segmented them into so many pieces is because of the access. Now, there are some patients who accept a coronal access straight away. So it's easy for us to actually expose this whole area and then place it as a single implant, while some are very, very finicky and they're very particular that they do not want a coronal approach and they want minimalist access approach. So in this particular case, what we've used is we've used a transconjunctival incision, we've used a sub-brow incision for accessing this area, and then we've slid the 4 implants into place like a jigsaw puzzle and placed an onlay augmentation. Now, the last section that I want to talk about in terms of reconstruction is our experience with cranioplasties. Like Professor Koteshwaran has already told you, we started basically with manual bending, like earlier the slide showed. So you have a cranial defect and then you have an orbital reconstruction that is needed. That's the outcome. But what was done basically was to form a cranioplasty mesh, which was done because of manual bending over an STL model. So this was the earliest method that we were following. And now from there, we've come across to use of digital workflow in designing multiple implants for a similar kind of defect or an even extended kind of a defect. Now you can see this where you have an extended cranioplasty design with a series of onlay implants as well as an intraorbital reconstruction, which was given for this particular patient. So that's the implant in place. Here again, you can see that we've used 2 materials here. One is a titanium implant, which was used for the cranioplasty mesh. And the second one is a zygomatic onlay implant, which was created with PEEK. And then a third one, which is an intraorbital implant, which is again titanium. Now we mix and match implants depending on the kind of usage that we need and if at all we need weight reduction. So that is the reason why we use multiple types of implants. Perforated titanium is also a very good option in these kind of cases, which actually makes the implants pretty light. So this is the postoperative outcome for you. Now, what exactly is the consensus on the use of PSIs for cranio-orbitofacial fractures? There is no significant benefit over preform mesh for internal orbital reconstruction as well as cranioplasty, except for the on-table time decrease. The surgical time is grossly decreased if you're able to pre-bend them. So if you're going to use VSP either in the form of using STL models and pre-bending your implants, or you're going to print your implants and then get them to the table, then you save on time significantly. Of course, the costing is a very important factor that needs to be included here. And it's extremely advantageous in secondary reconstructions for the cranio-orbital region. It's very, very beneficial in impure blowout fractures, where not only the orbit needs to be reconstructed, but also the facial bones along with it. And then you have extremely good outcomes when it comes to concomitant zygomaticofacial fractures along with orbits. And then you can, it becomes almost like a gold standard when it comes to concomitant cranioplasty defects. This is what literature says. And we have had a fair share of use of navigation, like Dr. Preeti has already told. We work together on a lot of cases, and we have formulated our own clinical indications of value in CMF surgery. We find that it is extremely useful for minimal access surgery in high-risk sites, especially near the optic nerve, as well as guided phase surgery. Secondary surgery involving complex orbitofacial trauma or orbitocranial trauma. This is one such example where you had an orbital apex syndrome, which was handled using navigation that made it more comfortable and predictable for us. It would definitely make life easy when it comes to revision surgeries, especially for the orbits or for the midface, where you have the zygomatic complex or the naso-orbitoethmoid fractures come into play. And it has a very important role to play in tumor margin assessments. This is a case of a revision orbit fracture, which was handled with navigation assistance. And it can be a luxury in routine primary trauma. So if you have it, you flaunt it. So for routine primary trauma as well as routine reconstruction for ablative surgery, if you have navigation and you feel good to use it, you can, but it does add a lot of intraoperative surgical time. So you must be actually prepared for that. To summarize, what I would like to say is computer-assisted surgery basically involves virtual surgical planning, use of patient-specific implants, guided surgery, which can range between intraoperative navigation to robotic surgery. It's quite useful in all facets of surgery, diagnosis, guidance, performing the surgery, as well as assessing outcomes. Now, this is a very simple algorithm that I picked out from the AOCMF guidelines on how to understand what kind of computer-assisted surgery you need for your surgical process. So you have CT data which is available, you have the pre-op planning, you have intraoperative guidance available. But depending on the difficulty grade, you can choose. So if it's a routine surgery, you can use non-guided surgery. If it's mild to moderate in difficulty grading, then intraoperative navigation would be the first one that you desire to use, because you know you're going to get it reasonably right. You just want to check whether you're able to achieve it right. So that's the second level. If you're finding the difficulty grade to be extremely complex, then what you need to do is plan the surgery first. There you need a big role for virtual or physical model planning, and then replicate the process in the theater using navigation. So this is pretty much the algorithm that we follow on how we need to choose what form of computer-assisted surgery that can help you during your surgical process. My sincere acknowledgements to the organizing committee for this particular webinar, Professor Koteshwaran for being a wonderful teammate and inviting me to this forum, as well as my other teammates, my oculoplastic colleagues, Dr. Preeti, Dr. Bipasha, and colleagues from Shankar Nethralaya in Chennai, and my maxillofacial colleague, Dr. Ilavenil. So these are the people I would wish to thank. And I thank you all for a very, very patient listening. I'm free to take questions if there are any.
Yeah, thank you, Professor. A very, very nice lecture. We do have work with maxillofacial and plastic as neurosurgical team in my place, and usually there are a lot of gray area overlapping. So we usually alternate between maxillofacial and plastic in combining surgery with us. My question is, Professor, there are conditions that sometimes a pre-op planning implant may not fit into the area, or sometimes we may need to remove certain extra bones just to make sure we do a great job. And do you think that how much there is a need to do intraoperative CT scan for 3D planning for patient-specific implant in those cases? How often do you need to encounter in this kind of condition? My second question is, if you have bilateral injury, what are mirroring that can be used for those cases? These are two questions for you, Professor. Thank you.
Wonderful. Thank you. So the first question is, how do you troubleshoot patient-specific implants? Yes. Now that's a very, very important question, especially in if you're looking at what I've spoken to now, cranial areas, facial areas, and orbital areas. Now, patient-specific implants are very forgiving when it comes to cranial and facial areas, where the fit is reasonable. We don't expect too much of difficulties in actually placing them. But personally, we have faced a lot of difficulties when you're placing intraorbital patient-specific implants. Now, that is a place where if you have intraoperative imaging available, yes, it can help in troubleshooting, but you need to be prepared with plan B. Sometimes the implant just doesn't fit, and you land up, because you're looking at a tight space. You put the implant inside, it may fit, but it may produce a tight orbit, and you don't want the globe to be immobile right on the table. You get a tight orbit, so that's going to be pretty challenging. And in these kind of situations, you need to be prepared for a plan B. You might as well carry a stock implant, which also can be planned virtually and kept. So you know how to position the stock implant when the PSI doesn't work. So that's going to be plan B, and it is always better to have a plan B. Now, the second part of your question is, how do you manage bilateral problems? Yes. Now, unilateral problems are very simple because you have a mirroring which is available. For bilateral problems, the idea is to use statistical models. So what happens is we generate statistical models for age groups. Not actually for every age group, but we have pediatric, we have adolescent, as well as we have adult statistical models. And the variation between male and female is also there. So maybe 6 or 7 statistical models we will have, which will be printed and kept. on the basis of which we can either use the STL file for planning, or we can use physical models for planning, depending on what you're going to use. For example, if you want to contour a cranioplasty mesh, you have a physical model, it's easier to do that. So you basically generate statistical models and keep, so that instead of mirrors, you use the statistical model for bilateral corrections. You have the STL file, you can always incorporate it into the computer and then use it for planning again. So that is how we manage if there's a bilateral problem.
Thank you, Professor. I think there's a question from Professor Pizat.
Maybe I could add a point to that.
Yeah,
There is
please.
Yeah, so I think your question was on intraoperative imaging. Right?
Yes.
So I would say that these patients are the tough patients where the orbits are shattered, and we want to be we want to have a double check and 3 times checking of whether the reconstruction is adequate. So when we design a PSI, we design it in such a way that it fits only one way. There is no second way in which it can fit, so that the contours are at the right places. Secondly, again, intraoperative navigation will guide us and tell us whether it is matching with the other side, if we have that. And thirdly, if you have imaging, it is another check whether your implant is in position and whether it matches with your planning. So you will have a mirrored planning with you, and then you will do an intra-op imaging and see if that planning is matching with your implant position. So these are all multiple checks that we do, and we still land up with residual enophthalmos. So if you have it, we can use it, but it is not a necessary if you have a patient-specific implant, if it is designed correctly.
Thank you, Professor.
There is one question. Someone raised hand. Dr. Liu? Okay. There is one question in the question box.
Yes, I will invite Professor Pizat. Yes, and then let us go to the Q&A. There's a question from Professor Jamal. Do you think 3D model design should be incorporated into curriculum of neurosurgical training? Panelists, speakers, can you, any one of you may answer?
Yes, it is, because the trauma volume of neurosurgical patients is almost increasing every day. So all these patients nowadays, we used to get only complex head trauma patients, not a simple trauma patients. So it involves multi-system, almost frontal, orbital, facial, and everything. So because the high velocity accidents are very common now, so the proper implants also should be taught in the neurosurgical curriculum. So how they should select the implants, how they should select the material, and how it should be used, how it should be planned, because we learned everything by practice. So it will take long course of time. So instead of that, we should cut short the time. We should have a part of their curriculum. We should have some sessions like that. So that is why I'm proposing this subspecialty for neurosurgeons.
Professor Pizat, any question from you?
Hello. Salam alaikum. Konnichiwa. Thank you, Professor Anand. Just I'd like to know what is your advice for the fracture involving the ear sinuses and for the reconstruction, and also for prevention of infection. What is your advice? And also this have a link to Professor Pretty presentation as well. Thank you.
So am I to understand that the question was on involvement of sinuses, the frontal sinus?
Yes,
you mean?
yes, ear sinuses for reconstruction. Yes.
Yeah. So the involvement of the sinuses have their own algorithm. So it depends on whether it's a monocortical fracture or a bicortical fracture of the frontal sinus. And if you have a bicortical fracture, you're going to treat it more aggressively with neurosurgical support, or you're going to obliterate the sinus. Make sure that you don't have any residual mucosa which can produce mucocele. But if it's going to be a monocortical fracture, then the problem becomes much more simpler to manage. It is easier for us to go ahead with primary reconstruction options. The reconstruction option for a bicortical fracture can also be primary, provided that there is a good team support where the primary intervention has been done to correct it in the primary stage itself. So reconstruction is independent of the management of sinus fractures. If the sinus fracture has been managed according to the need, then the reconstruction process can be finished at the same point of time. I hope I'm able to add clarity to that, to your question. It depends on the type of cortex that is involved. If it is a monocortical fracture, it makes it much simpler. If it's a bicortical fracture, you need a team in place where the neurosurgeon has to help us in handling the frontal sinus by either a cranialization or a obliteration. And then the primary reconstruction can be performed at the same point of time. It need not be staged.
Yes, I agree with Dr. Anand, because the problem happens to the patients, or the bad defects only happens because it was not addressed at the primary time. That is why this team was doing a primary fronto-orbitofacial correction when the patient lands up with multiple problems. So we start with cranium, then we come to orbit, we come to nose, then we come to face. So the process starts from the skull. So the primary part was corrected by a neurosurgeon. The next part was corrected by the oculoplasty or plastic and also fasciomax. So the complete treatment happens in the same sitting. That is why this concept was created. This is called primary fronto-orbitofacial correction. So as it was taught in the literature, the infection rate was not high. So as it was mentioned in the literature, if you address properly with expert team, the infection rate was very less. We don't encounter infections even if you address primarily all these complications.
Is there any further question? Prof. 𝒔𝒑𝒏𝒂𝒓, you may ask your question.
Thank you so much for again for these insights. So my question is basically cranialization of frontal sinuses. What kind of technique do you prefer, and is there special recommendations regarding this?
So frontal sinus, first of all, if the sinus was exposed, you should remove the mucosa. The second step, you should cover with pericranium. So you should obliterate the sinus. Even though if the dura was torn inside, if you obliterate the sinus, CSF leak will not happen. So that will not lead to any meningitis or infection. So whenever the sinus was exposed, remove the mucosa, cover with pericranium.
Continuing this discussion, recently we had a lecture from Professor Majid Sami, but he recommends not to remove the mucosa because its protective role in the frontal cavity. Rather leave it and close it with other material like fat graft or something other. What's your opinion regarding this?
We don't do like that because our patients in these kind of injuries, they're all infected. The problem is it is not an elective procedure. Maybe I don't have an idea about Professor Sami's opinion. This is a patients, they're all having infection prone because of the trauma. Because the nasal cavity already, if it is injured, already it is an infection prone zone. And also it will expose to the brain. So that is the routine practice what we used to follow. If the frontal sinus was injured and also exposed, if it is there is a chance for getting infection to the brain, better, that is the routine procedure we're following, is removing the mucosa and obliterate the sinus.
And what do you do in case of regular cases like transbasal surgeries and visualizing, when you visualize the sinus and after the surgery? For example, in case of cranial-based tumors, do you still routinely prefer to remove?
No, we don't. We changed our concept nowadays because if you have a illumination, for example, now what I'm using is we use the light source cable. Light source cable, no, at the end it will have an illumination. If you place the light source cable over the frontal area, it will illuminate and glow. So you can identify where the sinus is. Otherwise, if you have navigation, if you use the navigation, you can avoid the sinus involvement while looking the cranial exposure. So that is the way we are preventing the exposure of frontal sinuses nowadays.
Thank you.
Okay, thanks. Thank you, Professor. Since there's no further question, we may move on to our next speaker, Dr. Sabari Girish Ambat, who is a plastic surgeon. Now we have a plastic surgeon with us, a consultant plastic surgeon from Apollo First Medical Hospital in Chennai, and he will talk on scalp defect reconstruction. Thank you, Professor. Please start your lecture.
Thank you very much, Professor Liu. Am I audible?
Yes, Professor.
So, at the outset, I would like to thank Professor Kodishan for giving me this opportunity. It's a very good concept, which we really was there in front of us, but nobody put an effort to do something about it. You know, we all are available, but we never joined hands together. And it is good to see that somebody has really taken an initiative to do that. So thank you very much. And I would be straight away going to my topic. It's a scalp defect reconstruction. It will be a combination of things which we have planned and done, and then cases in which there had been some post neurosurgical procedure. There have been complications and some complex defects and some life-threatening defects which we were able to save. So I'll just run through them. So anatomically, of course, I don't have to tell you how specialized the scalp skin is and how richly supplied the scalp skin is. It is supplied from all the areas, and it has got its own blood supply network, so complex that it is not easy to devascularize a scalp flap. Having said that, it is one of the most unyielding part of the body, where the skin will not yield itself on its own unless you do certain procedures by which it can stretch itself. It's a very unyielding area, mainly because of the tissue structure called as galeria, which is there, which holds the thing in place. And what is an ideal reconstruction for any kind of scalp defect? It is usually the adjacent skin or the adjacent skin from the scalp. But not always it is possible to do it in the primary stage. So there are times when you have to stage it also. Having said that, the most important thing whenever you plan for a reconstruction of a skin alone defect is not to displace the hairlines. Do not distort the direction of the hairs, and avoid as much as possible scars due to surgery, which will eventually be alopecia and which will look ugly. So that is the main thing which you should remember. And of course, there are many ways to skin the cat. So not one is ideal. And according to me, the most preferable is a rotation flap, especially in patients who have hair. In somebody who is bald, it doesn't matter really much. But in somebody who has hair, something simple like a rotation flap is for small defects and all is the best, which gives you a result without any distortion. So for like this, it's for small defects, it is always a rotation flap or something similar to that. You can do a double rotation, you can do an S-shaped rotation, or you can do a pinwheel rotation where you make multiple incisions, but as less as possible to get a good result. And the most important thing is never distort the direction of the hair or the hairlines. That is the idea when you plan, you should always have it in your mind. And when the defect becomes a slightly bigger and a medium-sized defect, then you start thinking of big flaps, pedicle flaps, and which should be combined with what we call as galeal scoring. So, and the blood supply to the scalp skin is so good that you can base it on a single scalp artery with a small bit of pedicle of skin called the venous drainage, and the whole of the scalp will survive on it. So you can be very bold and confidently raise a flap in the scalp based on a single blood vessel which is supplying the scalp. It can be either occipital, in the back, on the sides, temporal, or in the front, supraorbital, or supratrochlear. So this is the same one which Dr. Professor Kodishwaran and we joined together and did. So the idea is to raise a big one, and this was based on the occipital artery and the superficial temporal posterior branch. And what we have done is the scoring. Scoring is basically done perpendicular to the direction in which you want the skin to move. And it is usually done 1 centimeter gap between, there should be a gap of 1 centimeter between each scoring. And every score which you do will usually give you a gain of around 1.67, approximately 1.5 millimeters. So you can go on doing multiple scorings, and that will help you in trying to close the defect primarily. So when you do the scoring and when you raise such a big flap, the aim is to primarily close without having a secondary defect which needs a skin graft, which in turn will lead a bald patch. So this in the same patient whom we were able to achieve a primary closure after we did a big large rotation flap. So the advantage of doing this is we never distorted any hair direction of the hair, nor the hairline was much distorted. For large defects before the era of microsurgery, where we can transfer large volume of tissues towards to any other part of the body. Previously, the idea was to do something called as articular flap or the banana peel technique, where I raise flaps based on these individual blood vessels and then score it and try to close the defect. But the greatest advantage of this particular technique is that it provides you with hair-bearing skin all over. But the problem is there will be multiple scars of the incisions, and sometimes, in spite of all these flaps and all this effort and scoring, sometimes you might not be able to close the defect completely, and you might end up having to put a skin graft on some place or the other. So it's not foolproof, but it's one of the wonderful techniques where if you have not much of microsurgical experience, it is a wonderful technique to cover defects which are medium to large size. So for example, in this, the another technique which commonly is done basically to patients who are of poor general health or who deny any major surgery, major procedure like a microsurgical procedure, is to do a transposition flap. This is always available, where you can raise a flap based on the anterior side or the posterior side and transpose, and the remaining raw area, which is left with the pericranium, is skin grafted. The biggest drawback is it is aesthetically not good looking. Why? Because you have a big dog ear, which happens to be seen on one side, and the other side is a big bald patch of skin grafted area. Having said that, we can do secondary procedures and put a tissue expander and later on expand the skin and correct the dog ear also. But the primary reconstruction alone itself is not very good looking, and it's unsightly. So we preferably avoid this procedure nowadays because we have better ways to do. So beyond that, if the defect is too large, none of this what we have been talking about so far do not work. So we have to transfer tissue from somewhere else to cover the defect. So this is a case of an angiosarcoma malignancy which was widely excised, and it was almost a subtotal resection of the scalp, and we were able to cover it microsurgically with a free anterolateral thigh flap, which we call as an ALT flap, which we raise from the thigh with minimal morbidity. And this can easily be connected to the blood vessels, either to the superficial temporal close by, or we can go to the neck and connect it. So the same patient who had after a good healing of the flap. And there are times when the the neurosurgeon will call us for such kind of problem where it's a post-craniectomy status, deformity is there. Somebody has attempted twice to put an implant and was not able to cover with the skin, and because the skin has got contracted and shrunk over the course of months and years. And so knowing very well that there will be a shortage of skin, it is wise to plan along with some free flap or some flap by which we can cover it primarily. So this patient was taken up for a cranioplasty as the parents desired to have a child with the proper shape of the skull. And this is the implant which was this was placed and fixed to the available native bone, and you can see the defect which is evidently there, which we could not close. So that is where when we come into play, and we had taken a muscle flap because there was a small risk of infection because they're tiny raw areas, and we didn't want to put only a skin flap. A muscle flap is more robust in blood supply and protects the implant also well. And we were able to cover it with the defect with this muscle, and we were able to connect it to the blood vessels in the scalp itself, to the superficial temporal, and we grafted it. The idea of putting a thin graft is basically eventually the graft will shrink, and later on, if needed, we can even remove the whole of the skin graft and primarily close it at a later date. This is the same boy in the post-operative period with a pretty decent shape. Sometimes you are called in to deal with a patient who is near dead because of an electrical burns, and come with a poor GC, and has sepsis, and has got whole of his scalp burnt off following an electrical burns, had an amputation of the left upper limb, which was the exit wound, and they had to remove and do a disarticulation at the shoulder level, and with deep multiple raw areas in the neck and the clavicular region. So this was a humongous defect where the most of the cranial bones over the parietal region and part of the frontal and occipital region was also completely burnt and dead. So looking into the poor general condition, we had to buy some time to get him out of the danger, and the neurosurgeons did a good job in getting him gradually out of with anti-edema measures and all, and with a good ICU treatment. And finally, we ended up having a raw area all around, which was debrided. And what we did initially was he was growing a very bad bug. So we had to chisel off the outer cortex alone of all the viable bones and allowed it to granulate so that we can buy some time. And this raw area was in the second stage split skin grafted to reduce the raw area and reduce the bacterial load. And once the infection was relatively cleared, we had to go in and remove all the affected dead bone was removed, and then we had to we covered it with a large anterolateral thigh flap, which we took along with a bit of vastus lateralis muscle because the defect was too big for one flap to cover. So we had connected finally to the blood vessels in the neck, and this is the post-op, and this is the defect. What we do when we don't have a good blood vessel in the scalp region is basically because in electrical burns the current passes through the temporal vessels. So putting it connecting this big a flap directly to the temporal vessels will be little tricky. So what we call as an AV loop, arteriovenous loop, is what we create with the vein graft and bring it close to the defect, and then connect this to the flap, and then we get anastomose the blood vessels. So this is the that is the AV loop, which is throbbing. You can see the pulsation, which is connected to the neck. And this is the same guy. We could save him, and he seems to be happy, and he prefers to wear a wig and a cap. Again, another case, unusual complication in a child who had a moya disease and came with a stroke. They had done a craniectomy, and once it was done, the child gradually improved and then suddenly started deteriorating again because the part of the skin flap was dead. And the neurosurgical team requested us to do something about it. And I don't need to explain to neurosurgeons what moya is. So I'll just go ahead. So this is the same child. Once we debrided the necrotic skin, there was a lot of dead brain with and other hemostatic agents like Sergicel and gel foam, which was there, which was all debrided. And we again went to the neck to connect it to the blood vessels and took the muscle skin alone flap, which is an anterolateral thigh. And we were able to get a good closure of the defect. And the second stage, again, we had to take up a little bit because there were small sinuses around with the discharge. And again, we had to go in and open it up and remove some more of the dead matter and some remnants of the Sergicel and gel foam, and then again resuture. This child went on to do well. And the same child, and it's amazing how children recover. A similar defect of electrical burns. What more can be done? In none of these cases, we prefer to do a bony reconstruction at the first go. We always prefer to, when we do such big flaps, we prefer to do it in a second stage. And the scalp where the electrical, this is a case of an electrical burns with a scalp defect similar to the previous one, but a smaller defect. And the first stage, we had covered it with an anterolateral thigh flap. And the second stage, the sequestrum was removed, leaving behind a bone gap, which was the bone was reconstructed using split rib graft, which we had taken from the right side of the chest. And following which, we had put two expanders. This is the advantage of once you have a good healing of the tissues, expanders can be put on sides, and the side skin can be expanded, and that can be used to bring in hair-bearing skin at a later date. So this is a post-operative result. So expanders, hair transplantation, all the adjuvant procedures are extremely helpful nowadays to create a good aesthetic result also. In conclusion, I would like to say that small and medium-sized defects of the scalp you can reconstruct with local flaps, preferably a rotational flap. Why? Because it doesn't distort anything. Large defects are best managed by providing an initial cover with any free microvascular flaps, and following which you can do a reconstruction of the clavarium with either a staged clavarium with a bone graft or a mesh or a 3D reconstructed implant, and that can be also be combined with the tissue expansion. Thank you very much.
Thank you.
Thank you, Savari. Thanks, Savari. It was the great talk. So as a neurosurgeon, I think for what you showed us the moya case, the necrotic skin, and thank you very much. Sometimes we encounter such case. So as a neurosurgeon, can you suggest us how we can protect or avoid such a complication? Maybe some vessel treatment, I see. If you have some suggestions.
Thank you for the question. I do understand the challenge when you have to open up a defect for a small child like this. The thing is, at any point of time, the base should have one named vessel within it, and the incisions should not cut through them. And as you plan your incision, it should have a wide base at the below, so that at no point of time there is any necrosis. The most important thing is to have a named blood vessel. It can be an occipital artery, it can be superficial temporal or a frontal. In the frontal region, it can be supratrochlear or supra. You should have something at the base which will. That is the most important trick, according to me.
Thanks a lot. Do you?
Yeah, thanks, Professor, for a very nice lecture again. I have three simple questions. We use, as neurosurgeon, we used to do some embolization of ECA, especially those we think that very vascular tumor, just to reduce the risk of bleeding. And I personally don't like that because sometimes it can cause screen necrosis. So do you think that there's any better way, in terms of that, whether plastic can help us to temporarily ligate the vessel so we can do a proper surgery rather than embolization? My second question, Professor, regarding the case that you show, moya defect, there are cases also the skin flap fail, necrotic, and also no underlying dura, and usually for plastic, the minimal requirement is the wound must be clean before they can do any flap. And that's the biggest issue for neurosurgery. We can't leave the brain open. So what, in your opinion, what's the best method to cover the brain to avoid further damage to the brain while waiting the wound to be healed or to be clean from any infection for the flap to be carried out later? My last question, sorry for my ignorance, I may not know this, because when we take the skin from other part, it is hairless. And I know there's a hair implant in plastic surgery. So is it possible now we do hair implant in those flap? Sorry if I have ignored latest advances in plastic surgery. Thank you, Professor.
Yeah, so I forgot the first question.
The first question is embolization of the ECA.
Yeah. So ECA embolization is done beforehand simply to reduce the vascularity of a tumor, which is basically supplied by ECA. So one of the easiest way to control the bleeding in the initial stage is to have a control at the neck before you go in to do the in the brain area. So you can always get a help of a vascular surgeon or a plastic surgeon and clamp it. Temporary clamping of the ECA is much more wiser than before the surgery. The control of the main source vessel at the neck is always possible. So rather than embolization leads to it will also cause problems in the superficial temporal vessels, and that again leads to problems. So it's wiser that it should be a temporary occlusion of the blood flow through that, and later on it should be able to reperfuse. So from the source vessel, if you can do that with the help of other colleagues, that will be better.
Second question on infected wound, flap.
Infected wound, unfortunately, it is this neurosurgical field, this is a big challenge, In neurosurgery, we cannot leave the brain open. So it is a very calculated risk which you have to take. And you have to debride, give it a good wash, and provide a vascularized tissue to cover it immediately. You cannot wait like other areas where you can wait for some time, allow the infection to clear with antibiotics and leave the brain exposed. for some time. You cannot do that. So my suggestion, my way of thinking is you have to cover it. But what you can do is, instead of connecting it to blood vessels close to the infected area, like in the superficial temporal, rather you go to a little faraway place like neck, where you're rest assured that your blood flow to your flap, which you are going to put, has got its own independent supply away from all the infection and the infected area. And muscle is always better. When you are really thinking of infection, muscle is a better source, because muscle will help you to control infection. And usually when you remove the dead tissue itself, you have got 90% control of the infection. The rest of the body will take it. And the third is we don't we can't put hair. We can put hair into those bald patches, but it is never as good as doing something like a second staged procedure, like a application of tissue expander, and later closing the defect. The best thing is to, at a later date, if possible, if you have decent amount of skin around, it is better to expand that the area and remove the flap in total, and cover it with hair bearing area.
Thank you, Professor.
Thank you.
Yeah, I don't see there's any further question. Thank you, Professor, again for your nice lecture. We move on to our last speaker, Professor Natalia Ben Shalom, who is Assistant Professor of Neurosurgery from Dr. Barbara Zucker's School of Medicine from the United States of America. He will speak on the art and science of neuroplastic surgery. Let's welcome Professor Natalia. Thank you, Professor.
Thank you. Can you hear me?
Yes.
All right. Excellent. Thank you so much for this invitation for a great symposium. This is really exciting for me, as we started this collaboration a few months ago, to see how the field of neuroplastic surgery is heading into a real subspecialty that I'm very much proud of and here to represent, at least what's happening in the US. I established the first New York neuroplastic surgery program from the neurosurgery component. So I'm a neurosurgeon by training, but as we all know at this point, there is a big lack of knowledge and expertise when it comes to neuroplastic surgery, and we decided to train and to start basically a new program. What I'll show you today is a high-level view of what we do and how do we look at things. Many of the things are going to be a little bit different, and many of the things are going to be repetitive for what we heard today. So bear with me. I'd like to start the conversation and show this image. All of those are my patients. And I would like to ask each and every one of you to guess which one of those patients, for example, had hemicraniectomy due to trauma, and they have a large skull implant made of 3D material implanted. And then I would ask you which one of those patients had a severe frontal sinus fibrous dysplasia, completely restoring his forehead. And then I would ask you which one of those patients has, for example, has had large brain tumor that was not only involving the brain, but also the skull, the dura, the scalp, and was the size of a large orange in their forehead. And lastly, I will ask which one of those patients has a computer inside their skull that monitoring epilepsy. So basically, if you think maybe this patient or the other patient, all those patients had some sort of cranial specific implants made of acrylics or mesh, and many of them had multiple injuries and traumas. So you would ask me, why do you show this picture? Because for me, this is what neuroplastic surgery is all about: is to bridge a gap between neurosurgery and plastic surgery. Is we're dealing with complex neurocranial reconstruction, and we want to ensure that patients have complete preservation or restoration of the preoperative appearance. We got the endorsement of the Journal of Craniofacial Surgery as being our host journal. And the first question that we ask ourselves, so what is that, right? People talk about hemicraniectomy and syndrome of Wiedemann. Do we have to fix the syndrome of Wiedemann or not? Is it a real thing? Is it happening only when this flap is sunken, or is it also happening when there is pseudomeningocele? And what I first, start to do coming here is to do a really thorough investigation of patients without skulls that coming in for cranioplasty to understand a little bit more about the syndrome. We know some patients get better, we know some patients don't, and we don't really know how to predict that. So what we do, we use those very fancy AI algorithm called QuickTome studies, and we do an MRI before and after. And we're looking also at perfusion and also at different networks that are associated with higher cognitive function, motor function, etc. And we're trying to understand, is there any change in the blood supply or the perfusion to the cortex that can manifest with perfusion changes to the network that can manifest in any meaningful changes to predict, will those patients get better or worse after cranioplasty? And this is, for example, a patient of mine. He's 27, he had a TBI, had acute subdural hematoma. Now he comes to look for a cranioplasty. Now, this patient works at the finance in New York City. He is very well educated. And, when you look at the literature of cranioplasty, there's a very high complication rates. 35, if you look across the literature, 35 to 40% complication rates. And he's a young guy. He wants to go back to work. He wants to build a family. He wants to make sure that the cranioplasty that he's going to do are going to be much lower risks. Therefore, in the founding father, where it's all started, this neuroplastic surgery official field at Johns Hopkins said, let's look at the technique, timing, and materials to basically understand how can we get better outcomes. Now, why is neuroplastic surgery so unique? Why is there such high complication rates when it comes to cranioplasties? So the way that I view it is, as neurosurgeons, we're working on the net. We are focused on the brain, and we focus our research efforts on the brain, blood vessels, trauma, ICU. Plastic surgeons focus all over the body. They focus on tissue rearrangement and focus on free flaps, but there is no dedicated person or field for those patients that are adult and have neurocranial issues. This is why this is what I call the no man's land that we try to focus on. So our plastic surgery colleagues know this term oncoplastic surgery for quite some time. If a breast cancer woman get diagnosed, she will see the breast cancer surgeon and then the plastic surgeon, and they would go for the OR at the same time for oncoplastic reconstruction. If a brain tumor patient get diagnosed, you see us as neurosurgeons, we take out a tumor, but what if they have problems after? What if they have temporal hollowing? What if they have scalp dehiscence? What if they have a device exposure? Then some of us are lucky and have colleagues from plastic surgery or craniofacial surgery that can help us. But many of us don't really have good understanding of how to treat those neurosurgical patients. And this is an example of case that I had to review. This is a paper that was published in December of 2023. They asked me for my opinion. This is a patient with, as you see, a TBI, left ICH, hemicraniectomy, got a mesh cranioplasty, scalp exposure. And what they showed in this paper is after 16 operations, this is the final solution, as you see in D. He had multiple free flaps and graft and rib graft, and this is how he now is completely healed. This is still in 2023, and this is not acceptable in my opinion. And when you look at our studies, and we studied 500 cranioplasties, half of them came directly to us, to Johns Hopkins for cranioplasties, and half of them were revision, meaning somebody tried to, reconstruct the patients, and there is failed attempt. And we found that when you had your cranioplasty elsewhere, there is a 3-fold increase in the incidence of major complications as compared to primary cranioplasty. And this is not surprising. This is why we decided to build a center of excellence, which will treat the East Coast of the United States. And we see patients from all across the country to deal with this tertiary case for very complicated cases. And I want to show you an example. This patient went to an outside institution with his left temporal fistula. This guy had a TBI with a cranioplasty in the 70s, and he did very well. He was independent until this started to come out. He underwent multiple attempts at outside hospital by great surgeons, but this is what happened next. And this is when they called us to try to help him. This is another case, multiple squamous cell carcinoma surgeries. Now with open scalp, the patient is too old to withstand free flap. She's very sick. What do? Do you just let her be? She has a tumor that is involving the scalp, the bone, the dura, and the supraesophageal sinus. Nobody wanted to treat it. That's why neuroplastic surgery comes into play. It's another case of a meningioma that was involving the sinus, the scalp, the skin, and the bone, and it was resected and unfortunately got infected. And then they called their colleagues, and this is when this is what happened next. So those are the type of things that we see on a daily basis coming in from other institutions to try to address those very complex cases that either were untreated or deemed inoperable. And I'm very proud to show that we wrote the first book chapter at the Schmidt and Sweet Operative Neurosurgical Technique in the United States. Every neurosurgery residents that start residency gets that book. And now he can read our chapter about the different principles for scalp and skull reconstruction. So if I think about neuroplastic surgery, is this hybrid? Is this field to bridge the gap between plastic surgery and neurosurgery, and has the potential to touch every subspecialty in neurosurgery? And I'll show some examples. This is another patient that came to us from another institution. She had a very aggressive skull-based meningioma. She was treated and operated multiple times, including resections, free flaps. And after the 8th or 9th surgery, she was deemed non-operable anymore. They told her, we cannot really help you. The tumor is regrowing too quickly. Radiation did not work. And she came to us for another opinion. And this is one of the cases that we have to think outside the box, and we actually offered her first-in-human implantation of cesium brachytherapy in skull-based implants and got her gross total resection, and she's doing amazing. Why do I show this? Because this is where multiple specialties come into play. As you can see, this involving the brain, the scalp, the bone, the facial structure, the nose, cavern and sinus. It's not a one-man show. Neuroplastic surgery requires multiple people, multiple professions to work together to have those extremely hard cases. We use a lot of 3D printers, as one of the colleagues, some of the colleagues showed. We are basically, using our labs. We have Northwell 3D labs to help us design and print models with pathologies and without pathology, help us with the cutting guides and reconstruction, and give us those models to have not only a physical representation, but also a way to augment some of the data with virtual reality. And I'll show that in a minute. So when we look at a 500 cranioplasties outcome, we found that when you do the specific cranioplasty in a specific way and you dedicated a team of people, we reduce the complication rates from 36 in the literature to 15%. And this is why we suggest and we understand that to optimize the outcomes of cranioplasty, a multidisciplinary collaborative approach is needed. So I'd like to show this young guy that I showed in the beginning of the presentation. We use next generation implants. We are understanding that we have to push the field forward, and our implants not only overcoming hard and rigid skulls, but also soft tissue. And we know that now for all my tumor cases, we can print those basically very specific implants with heat maps and cutting guides together to be able to resect and reconstruct any tumors that are involving the skull. And the upcoming, not so long future, we will be able to implant technology into those skull implants. We're working with many providers and industries that support our work and initiative to be able to understand how we can do better when it comes to patient-centric problem. So this is the same patient. We do the left pericranial only technique. We elevate the scalp into layers. We leave the pericranium and we put this clear polymethyl methacrylate implant into position. And I'd like to show you the final.
Well, a patient who was left with a deformed skull after a life-saving procedure is back to living a normal life thanks to a medical team at Lenox Hill Hospital. Leading the team, the world's first neuroplastic surgeon. Eyewitness News reporter Sonia Rincon with more from the Upper East Side.
This is what Tucker Marr of Manhattan looked like only a few months ago. He loves playing hockey, but it was a tumble down a flight of stairs that landed him in emergency brain surgery.
I had a fractured right skull and a left-sided subdural hematoma, so brain bleed.
The surgery saved his life by removing part of his skull, since pressure on brain swelling can be fatal.
So for a while, that looked very normal, right? My brain was swelling, so it replaced that area.
Then the swelling came down. He wore a helmet to both protect and conceal.
It taught me a lot about how we as society and humans deal with deficiencies in other people.
When he came to us, he had a severe deformity and a dent in the side of his head.
But putting back the old piece of skull bone carries a risk of infection. Dr. Nadi Ben-Shalom at Lenox Hill Hospital is the first neurosurgeon to develop a specialty in neuroplastics, minimizing risk by 3D printing implants made of acrylics and performing a second surgery.
There are a lot of patients survived brain surgery, but they don't look like themselves again. They don't feel like themselves again.
This is what Tucker's implant looks like. It's reinforced with plates and screws. Dr. Ben-Shalom added extra ones, he says, because he wants Tucker to play hockey again.
The brain functions better when it's protected.
It may seem like a no-brainer, but Dr. Ben-Shalom's work, marrying neuro and plastic surgery, is catching on.
Everybody can do everything else the old-fashioned way, I think, and I really believe this is a very novel subspecialty that's going to take off, and we'd like him to lead it.
Tucker Marr's scars are healing, and he's training to run the New York City Marathon, just as he was before he fell. With a reinforced skull and sense of optimism, he says he hopes to motivate others who may find themselves with challenging recoveries.
It does come. It doesn't matter how long it takes. It does take that mindset, and you have to keep moving.
So basically, this was a very interesting case. It was featured on the New York Times because we used this clear polymethacrylate implant. It's sonoluscent to ultrasound, and it was very exciting. He actually ran the marathon. And when he come to the clinic, this is me and my chair, Dr. David Langer, putting an ultrasound onto the patient's scalp and looking at the brain. It's very reassuring. Patients love it. We're looking into different anatomical variation as well as pathologies, and my special interest is with brain tumor recurrence. But basically, when the patient comes into the clinic, you can open the ultrasound, look at the brain, and give a lot of reassurance. There is no hydrocephalus, there is no midline shift, there is no epidural hematoma or seromas, and it became like a little new stethoscope. This is new for us, so we are collaborating with experts. You see here one of my colleagues. He's actually from a gynecology department, but he's a world expert on fetal brain ultrasound to teach us and show us how we can better understand and look at the brain with ultrasound at bedside. And we're having a big, clinical trial that includes multiple different hospitals to look and investigate, basically collecting data with brain ultrasound in adults, and this is very exciting. This is another case of a young guy after a motor vehicle accident. He came to the hospital GCS3, had a bifrontal craniectomy and then cranioplasty, and he recovered amazingly well. He had an amazing recovery at an outside hospital. He then goes to multiple different doctors to try to do fillers and injections for this bitemporal hollowing. As you can see, this guy is young. He wants to go back to his normal life. All those injections didn't work. He come to us, and we know that every time we go back to put an implant or to dissect after multiple operations, there is increased risk for the injury of the frontal branch of the facial nerve. So what I did, I adopted the subcortical mapping technique from my brain tumor surgery into the craniofacial component or the neuroplastic component, and basically 3D printed temporal implants that are patient specific, but the dissection was done with concentric and electrified bipolar. So every time I get close to the frontal branch of the facial nerve, I stop. Why is that? Because you don't want to fix one problem and give a patient another problem. So this is how we push the field forward. And this is how it looks like just 3 weeks after to remove the staples with a correction of the bitemporal hollowing. His story was featured at the New York Post. So, the future of cranial implants is not only to be able to reconstruct form and function, but it's embed technology. And this is one of the 3 cases that we did. As you see on the left side, this is an RNS device. Basically, it's a neuroplastic device that can stop seizures in drug-resistant epilepsy patients for up to 80%. This is a wireless ICP monitor. We know that some of the patients either has hydro or her flap was never sunken enough and they have a tight full brain. We can now measure their ICP for 30 days just with a remote control at bedside. And for patients that you know that they're going to need a shunt and a cranioplasty, we can now embed the shunt and recess into the hardware. This was featured 2 years ago in the Journal of Neurosurgery to show you how we can use the cranial implants and where is the future of it. And I'll share some of the information. I'm very privileged to be participating in this BCI, brain-computer interface cases, when this guy had basically spinal cord injury C5, and with this multi-million-dollar, I would say, research team, we implanted 5 electrode arrays in the primary and sensory motor cortex, but those arrays are connected to those pedestals, and he has to walk with those pedestals for several years for him to get any benefit. And he actually did. After 1 year, was able to elevate bilateral arms and have sensation in his hands, which is very exceptional. But what I wanted to show you here is actually what our orthopedic surgeons are already doing years. So when you look at the orthopedic surgery implants, they can now implant technology within their knee implants to give a lot of information and sensing ability to guide the orientation of the implant. So ask all of you here to think, what is the mindset and innovation that we need to have as neurosurgeons to implant neurotechnology in our adult patients? This led me to be taking place with this NIH-funded grant to reconstruct the vagal nerve at Feinstein Institute. And to basically summarize, if you look at the evolution of cell phones from 73 to 2021, we've made a tremendous amount of effort and technological advantage when it comes to cell phones. We are still lacking when it comes to cranioplasties, right? So we used to have those gold, plaques back in the prehistoric area. And then we used to implant bones in the belly. Then we use the off-the-shelf implants. Now we use customized cranial implants with technology in it. So this patient can be a trauma, a stroke, an epilepsy, hydrocephalus, or even Parkinson's or tumor patients. Using those implants with added volume can actually have a lot of benefits when it comes to both understanding, getting information, and biometric data. I want to show you a few cases before I'm done. So this is the patient that we saw in the beginning of the presentation. He had a liver cancer, hepatocellular carcinoma. As you can see, there is a large epidural, basically dural-based mat involving the dura, brain, bone is completely destroyed, and then involving the scalp and soft tissue as well as supraesophageal sinus. What we do is we basically take all the information that we gather with imaging, we print those STL files, and then with augmented reality, as you see here, we take our goggles and we can look at, in virtual reality, real time on the model, at all the difficult structures and anatomy and our cutting guide, reconstruction, and so on. And this is how it looks in the end. Basically, we use here a very special cutting guide technique with customized implants to reconstruct him in a way that this is just 3 weeks post-op. This patient lost his forehead for SNUC. He had nasal carcinoma that was undifferentiated, and he lost his forehead to tumor and infection. And what we do is we do the 3D printing beforehand, and then we take the mesh, and in the office, I bend it, I shape it, I cut it. So then when it comes to surgery, I have it as off-the-shelf implant to completely reconstruct him. In this case, I also use cadaver skin to augment his scalp to withstand chemo and radiation, as we know that mesh implants with thin scalp can get exposed. We use acellular dermal matrix to augment the scalp before treatments. This is him 3 weeks post-op, and this is him just last winter. This is all about collaborations, and this is the last case I want to show. This is the patient who lost his skin for squamous cell carcinoma. And basically, we need to think outside the box and have a group of thinkers and collaborators to help these patients. And I have to say thank you to all my colleagues and partners at Lenox Hill Hospital, including our neurosurgery colleagues, ENT colleagues, head and neck, our industry to support us to be able to give patients, the great solution that they deserve. Skull deformity are necessary evil to be accepted with resignation. That was done. That was a correct 1947. It was a chair at Johns Hopkins. Not anymore. We're growing very rapidly with the neuroplastic surgery component, as there are only 2 or 3 programs in the country to offer that very specific, unique skill set. We've been featured in mainstream media. This is the patient that lost his forehead for fibrous dysplasia, and we removed the frontal sinus. We accentuated and obliterated so he can run 3 marathons in 1 year, just 6 months after surgery. This is last year's CNS. I gave a live surgery to a big audience where my chair, Dr. David Langer, my collaborator, Dr. Ron Bornstein, and the patient was in the audience, and basically showed other surgeons how we can use clear cranial implants to look at the brain with ultrasound. We do a conference once a year to look at the advances in neurotechnology that comply with neuroplastic surgery bootcamp, as a residents and trainees love to now learn about neuroplastic surgery, not only in real life, but also with cadavers and models to learn how to reconstruct patients after different approaches. We're leading the field of neurosonography to teach and understand much better on how we can use ultrasound in adults. And that led us to establish the meningioma program, as we understand that many of the patients that has those aggressive atypical meningioma, that some of them, we don't understand their biology and how they can be grade 1 and still involve critical structures like the scalp and the bone and the sphenoid wing. And we are now establishing sort of the group thinker to have a lot of different providers, including neurosurgery, skull-based surgery, plastic surgery, ENT, radiation oncologists, to push the field forward in what we can provide to those patients. As I said, this is all collaborative approach. None of this can be done with just one person. Need a lot of support by our colleagues, our mentors, and our residents and fellows. I can proudly say that we're operating now on multiple institutions on the East Coast, mainly New York State, but get patients from all over the country with complex stories. And this speaks for itself. This is our internal newspaper that comes every month, and we're being featured on almost every episode. This is a new niche that does not exist in competitive market, and it draws a lot of attention to our institution. And to summary, this is neuroplastic surgery, as I see it, is a program that could provide premier international designation to state-of-the-art neurosurgery, advancing the boundaries of medical innovation and patient care. And this is the most important thing in the end, is your family, take care of them. And this is my family here in New York. Thank you for inviting me to speak in this distinguished seminar.
What a wonderful talk. I must congratulate you.
Thank you.
We really enjoyed the talk. Thank you.
Actually, he's on a holiday now, so I disturbed him multiple times to come inside. It's a great talk, Dr. Nathi.
Thank you. Thank you so much for having me. I really appreciate that. I'm happy to take any questions.
Well, thanks so much. How can I call your name? Is Ben Shalom. Thank you very much. So, and you showed the last slide about the demonstrative surgery for young neurosurgeon. That is very, very important, I think. And in Japan also, we have just started the kind of the neuroplastic surgery and also the cosmetic surgery attached to some neurosurgical technical conference. I think your field is very important for the neurosurgical field, I think. So maybe we can collaborate in the future. So just so you can support us.
Absolutely. Please. Thank you for that. I mean, I'm very passionate about it. And what I do 90% of the time is give talk and educate both patients and providers and doctors and around the world to let them know that there is a new subspecialty. So for you saying that, I'm very humbled and I'm very grateful that our international colleagues understand the value and the importance of this. I think we're still very young and very small in that sense that we are not established as the main subspecialty, but every time, let me tell you, I give a talk, more and more residents, neurosurgery residents are interested to know and learn and train. So, thank to you, Dr. Kato, and thank to Professor 𝒂𝒂𝒂𝒂, and basically, we can really elevate and push the boundaries and teach and collaborate. This would not be able to achieve by one person doing it. I think that us talking together and really educating and working to establish this and basically showing great results as we already are is what will drive that forward. So I'll be very happy and humbled to collaborate in any mean that you see fit. As you said, this is Sunday morning in New York, 6 a.m. in the morning, and I'm here. No question about that.
Thanks so much. Thanks so much. So maybe I want to invite Dr. Fawad from Afghanistan. You may have some questions.
Okay, salam and thank you. Thank you very much. We have also a problem with scalp defect in Afghanistan as well, and with limited resources. And it's very useful and excellent presentation, and we learn a lot of you and all of our colleagues. Thank you very much. And we are waiting that we have a chance to have some training, send some of our colleagues for training if the situation of our country become good and in the future, inshallah. Thank you.
Absolutely. And I can leave my email here if you have any questions or you want to reach out with anyone with any patient-specific questions. I'm more than happy to collaborate or even virtually on those cases.
Yes, we are starting on WhatsApp group for this. And also on the heading of Professor 𝒂𝒂𝒂𝒏, we are going to start one neuroplastic committee. So Madam just proposed that. So in course of time, we'll collaborate together and we'll propose this field to the world.
Yes, it's excellent.
Thank you.
Thank you very much. So 𝒔𝒐𝒇 or Dr. Jeremy, your final question to him, please.
Thank you, Professor Kato. Just want to say it was a wonderful lecture, and thank you, Dr. Ben, for the wonderful presentation. Thank you.
Dr. 𝒔𝒐𝒇?
Yeah, thank you so much, Professor Ben Shalom. That was very exciting, wonderful lecture. The up-to-date and latest techniques of cranioplasty. I haven't seen this before. And I think the idea of spreading neuroplastic subspecialty to the world and expanding the idea into the international community, neurosurgical community is very important because neurotrauma cases everywhere, and we come across these cases basically every other day, and we have to deal with the patients with a correct, proper position. And I think that's very important.
Thanks so much.
Nathy, I have a question. What is the advantage of that implant? You are saying no, some chips are placed in the implant.
Yeah, so when you think about CAD/CAM, computers, associated device manufacturing with 3D printing, first of all, this clear implant is made of polymethyl methacrylate, and this implant is sonolucent. So as I showed, you can look at the brain with ultrasound. So patients come in, even all my GBM or meningioma patients, I will drop a little disc inside the bone flap. It can be 3 centimeters. They come to the office and I would just put an ultrasound, and they look at the ultrasound and then say, well, there is no hydrocephalus, everything looks good, the brain is pulsating, there is no epidural hematoma. It's give those patients a lot of reassurance instead of waiting for a CT or waiting for an MRI or whatnot. So this is one thing. The second thing is, with computer-assisted design and manufacturing, we can design and change the shape of the implant, not only to mirror the other side, but add some volume or recess stuff. So every time, for example, I do a shuntoplasty, a shunt and a cranioplasty, I will recess the shunt inside the implant so there is no extension or high-profile device on the scalp. for this wireless ICP monitor or RNS devices. And we know that more and more devices will come into practice, especially with brain-computer interface, that will need to be housed in an implant. And we are understanding how to design the implant to perfectly house those devices while still following the natural curvature of the scalp. And for example, all my temporal defect patients, you know, the way that I used to treat cranioplasties was to mirror the bone on the other side. But then what happened with temporal deformity, you know, you elevate the muscle and then the muscle drops. So what I do now, I design those implants to overcome the soft tissue as well. So they give me volume not only for the skull, but also for the muscle. And in that way, I don't even have to touch the muscle. I don't have to elevate the muscle from the dura pericranium. I leave it intact. I use the pericranial only technique, and I put the implant on the muscle with a compensation. So for those things, I think that you and everybody here needs to think, how do we make a change and how do we drive that forward existed and available technology, right? So what I would like to leave everyone here is to think, if we have the technology and we have the printers and we have the computers, what else do we need that we can do with those specific implants? And you and everybody here will be the one to say, well, you know, I had a patient with a hydrocephalus, or I had a patient with sunken flap. I wish I could see if there is, let's say, epidural hematoma or seroma, because there was a lot of dead space. Maybe I can implant an ICP monitor to tell me if there is high pressure that will send the information to my phone, right? We know this technology exists. How do we implement that into our practice is each and every one of you, you know, I would say, mission to think and to create. And this is what neuroplastic surgery is all about.
Right. So the thing is, how will you fill the temporal hollowing with the implant itself, or you will place some fillers over that implant?
Implant, just the implant itself, the way that our engineers, we work with very good engineers, and what they do basically, and I can show this one picture again, what they do with the design, they change the orientation of the implant to basically have more volume. I can show you this one picture here. Let me share that. Do you see that left-sided implant?
Yeah. Yes.
So you see it's going all the way with the same line of the zygoma, of the zygomatic arch. So the implant does not have the inner curvature towards the sphenoid being and temporal bone. It actually goes all the way down to the zygomatic arch to give this extra volume. So now they mirror not the bone on the other side, they mirror the skin on the other side. And this gives amazing results to all our patients. And I don't touch the muscle. I don't have to elevate the muscle. There is no bleeding from the muscle. And in fact, I believe that the muscle for TBI and stroke patients acts like a moya, like an indirect bypass. If you think about it, patient after brain injury or a stroke, when you do the hemicraniectomy and you put the dura in the muscle, I believe that there might be some connection. The brain actually, use this high flow state of the muscle to help resorb, some of the blood supply to the diseased brain. So I don't touch the muscle. I elevate the scalp with the pericranium is on the dura, and then the implant fits like a puzzle piece to reconstruct the temporal defect as well, because we mirror the soft tissue on the other side.
Okay.
Yeah, I had a small question, Dr. Ben.
Yeah.
How compatible is your screw fixation on a PMMA? Like, you will have two different materials. And how well is it compatible?
Yeah, basically all our PMMAs we use the self-drilling screws. So if you compare the drilling of a bone is almost the same. The PMMA, the clear PMMA is a very hard product. So sometimes you might have to even use a little bit more force with the self-drilling screws, but it's basically essentially like screwing with a bone. I don't need the pilot holes. I don't need to drill the holes. It's actually, it's going very easily and very smoothly with self-drilling screws, just like a bone.
And if you just have a temporal hollow without the extension on the scalp, You're going to place the implant just beneath the skin, over the muscle,
Yeah.
right?
Yeah. Yeah. So if it's primary, so the question if it's primary or secondary cranioplasty. If it's a primary cranioplasty that I'm the first guy to do it, I will design the implant to overcome the defect. If it's a secondary, meaning patients had cranioplasty elsewhere and they already have an implant and they have a defect, then I will use porous polyethylene MedPro implant that has a very specific pterional design, and I will attach them to the implant. Why do I use hard fixation? Because studies that show that anytime you use soft tissue, even muscle graft, fat graft, injections, they have no vascular support because of the implant, so they cannot survive. So they work for a few weeks, maybe a few months, and then they disintegrate. The only way to have a permanent temporal hollowing correction is with rigid fixation. That's why I use porous polyethylene. And as I show what we did here, because it's, you're going into a tissue that is already scarred down, we monitor the facial branch to avoid injury. So we don't want to give the patient, ptosis after that type of procedure. Again, the fixations are the same. You use a self-drilling 4 or 5 millimeter screws through the implant to the bone, and it works pretty well.
That's interesting. I think we're going to try that.
Yeah, we didn't do that. So we are actually filling the fat.
Yeah. I have
okay. Please, go ahead. One more question, please. Preeti?
No, I think I was just telling that I have a patient and we should discuss on the group that Dr. Kovishning was suggesting so that we can advance this in India slowly. Each patient we can discuss under his guidance and start.
Absolutely. I would love to share knowledge, discuss cases, and obviously get your expertise on cases that we're doing that are very unique. And I think if we can formulate a group of thinkers and sharing information, that would be amazing, as it's a very unique opportunity for us to build a new subspecialty around the world.
Yes.
Thank you so much.
Thank you so much. So, Dr. Liu, do you want to say something?
Yeah, thanks, Professor. Thanks, Professor, for futuristic talk. Actually, I feel that neuroplastic concept is part of the minimal invasive neurosurgery. We respect the brain so much, but we neglect the bone, the skin, the muscle, and it's time for us to take care of those things. And in my practice, if I do not need to remove the bone, I will do autoplastic flap for the temporis. I won't remove temporis muscle from the bone, and I think the attachment of the muscle to the bone is very essential. Even if you need to remove the bone, I think in the concept of neuroplastic, we should do early cranioplasty to preserve the function of the muscle, because the muscle is not only for cosmesis, it's also for mastication. So I think this is very important. And also for the same concept now, for whatever reason, frontal lesion, I will try to avoid frontal A sinus. However size is even the large, because we have the technology, we have endoscopic that can avoid going through the sinuses. And thank you, Professor, for bringing up all these important points in neuroplastic in our surgical practice. Thank you. That's my comment. Thank you.
Of course. Thank you. Thank you. I would add to that my practice is both brain tumors and neuroplastics. So I try to combine my neuroplastic technique in all my brain tumors, and basically from the incision, avoiding frontal sinus, working on the hair-bearing lines, and avoiding temporal hollowing, and obviously patients that if I can use, let's say lateral orbitotomy to enter scoliosis lesions and do transorbital surgeries to do minimally invasive violation of the muscle. I think that having that understanding, as you stated, of not only the brain tissue but also the respect to the muscle and the fascia and the fat and the skin will allow us to step up our practice into the next level of things. And I see a lot of patients after, let's say, glioma surgery, after chemo and radiation, when their scalp is breaking and they have a recurrence. Many patients don't want to touch it anymore, right? Many surgeons say, well, I think that we maximized your surgical approach. But I say, for the most part, the challenging part would not be the removal of the tumor, right? It will be reconstructing the scalp that is broken down, atrophic, and this is where I feel very comfortable to treat those patients. and offer them more surgery if indicated to not only remove the tumor, but also reconstruct the scalp and the face and the dura in a way that wasn't really available before.
Thank you, Professor.
Thanks so much. So today's we learned a lot from all of you, and we have the big conference in such as in Africa or some other place. So maybe we can invite you, and maybe you can invade, of course, not only the developed country but also the developing countries such as Africa or some other Latin America, something like that. So maybe I think we have lots of the discussion among the young neurosurgeons, I think, so that we invite more and more. Please join us. Yeah, thank you so much for your great lectures. We had a very great time with all of you. Thank you very much.
Thank you, ma'am.
Thank you.
Thank you, Professor Kato, for chairing this session, and we can close the session officially. Thank you to all our speakers. Good night and bye-bye.
Thank you, Dr. Liu and ACNS team. Thank you all
Bye.
for the speakers.
Thank you.